once again physically for a NAFLD Conclave. It's a pleasure to host it this time here in Delhi, and we'll try to make sure that your coming here was worthwhile. I'm beginning even when the hall is not very full because I'm literally scared of some of my friends. And the person whom I must mention is K.R. Palaniswamy. Palani is a stickler for time. So once there was an American guest who was giving a lecture and he overshot time, and Palani, in his typical quiet but brutal manner, got the slides to go off. And you know, this fellow, he anyway belongs to the same part of the country. He got agitated and said, nobody in US ever dared do it to me. So, you know whom I am referring to. And so that's what Palaniswamy is all about. And I literally take his sense of punctuality with a lot of seriousness. Okay? So that was just to liven you up, and I'm beginning a little bit. We are changing the sequence because the hall is still not full. Some people have landed, they're on their way. So I'll make a very brief presentation about Hope Initiative and why we are doing this, so that some of you are at least aware of it, and then we will go through a few of our felicitation programs. So NAFLD, as you know, is no longer just a matter of cosmetic problem of obesity and all that. I mean, we have people now dying of it. And I can see some of my friends from some parts of the country, I think Dr. Narendranath, and we know that some of our colleagues have actually succumbed to metabolic disorders, and it's been sad. So it's getting to be a serious problem, and we really need to take cognizance of it. I won't go through the statistics, but it is related to a large extent to our faulty lifestyle, the way we are piling up kilograms of weight, and diabetes and hypertension. And it's now becoming a major killer. We have been having this NAFLD Conclave. This is the 6th in a row in a series. And earlier on, it was thought that is it really worth wasting a day on a topic which is as simple as just extra fat in the liver? But it appears that it's worth it, because there has been a huge amount of both research on the biomedical front as well as a huge amount of effort by people to try and see how to modify behavior, how to bring in government policies and so on and so forth. So it's no longer a very minor issue that we can brush under the carpet. So we have been having quite a few of these sessions, largely led by one of our illustrious Indians settled overseas, that's Dr. Arun Sanyal. Arun, for those of you who don't know him, he'll of course be formally introduced. He made his beginning in India. He for a while was at All India Institute. I think we were contemporaries at that time. Then he moved to US. And it's a matter of pride that he's become a real top-shot hepatologist of the world, and is perhaps the international leader on fatty liver disease in the world. So when he comes here, he brings with him a huge amount of not just information and knowledge, but a lot of insight. And that's what we really value about Arun's coming here. He's, by the way, the course director for our NAFLD Conclave. What does NAFLD Conclave deal with? Yeah, the main aim has been new therapeutics. And there's a lot of research going on. So we need to know what are the drugs coming, which ones are falling by the way, which are the ones which are standing the test of time, which can be used and when. But there will also be case-based discussions of understanding how to apply it in practice, and a little bit of reminder or nap on the knuckles, so to say, rap on the knuckles, so to say, that we have to be more mindful about our lifestyle. For Hope Initiative, HOPE stands for Health-Oriented Programs and Education. We started in 2004 with a partnership with the WHO and UNICEF, and it was the first health-promoting hospital in India that we created at Sanjay Gandhi Postgraduate Institute. This is after I returned from a WHO fellowship from the University of Sydney. I found that exciting. And more important, there was no competition. So there were no Vivek Saraswats, Ghoshals, and the Rakesh Agarwals after me, because I was doing something in a totally different arena, public health, which I really enjoyed doing. But yes, it's been a long story. We have covered more than 22,000 schools, huge number of programs, and now we have expanded to many other parts of the country beyond the 70 districts of UP that we had worked in. The part of hope is not didactic lectures, but getting people to feel that this is the change that needs to come. And I think the most difficult thing is behavior change. And Ashish, my colleague, is an expert. You know, it's very important. It's easy to tell people what is the scientific fact, but it's very difficult to get people to change behavior. And why we focused on kids was because kids were more willing to change behavior and were more open-minded than adults. Adults hardly ever do. And I was, in my perseverance to get other people involved in this group, I managed to strike a little bit of gold once in a while. And one of them is K.R. Palniswamy, my friend from Tamil Nadu. After much reluctance of about 3 to 4 years of persuasion, he finally jumped in, and he's now leading one of the very major attractive programs of hope for children in Tamil Nadu. And it's been a pleasure. I have worked with him on 2 occasions, and I would encourage many of you to invest a little bit of your time in contributing to society in other ways than just in the clinic. So, you know, in the clinic, you're basically advising one person and his family. When you're doing it with kids, you are actually preparing them for the future ahead for them. And there is something called a school to community approach. So they are going to go and tell their parents, this is what I learned, and many a times the parents also listen to the kids, okay? I think one of the best examples have been the change in use of crackers in Diwali. You know, much of the decline has been led by school children, and they have influenced their parents to change their behavior, which I think is very good. We have a few books, of course, in 6 languages. I think the Tamil version is doing very well with Dr. Palniswamy. The Hindi version did very well in UP, and now we are doing it in Delhi NCR as well, and we have the English version and few others. We have had our little share in the limelight. Hope Initiative was the only chapter from India in the case studies in global school health promotion published from Boston by a group of school health experts, and in fact that was a major achievement for us. We have 6 movies. And now I'll come a little bit towards how does hope come into this NAFLD Conclave. So health promotion is health promotion, be it with students or be it with the community or be it with doctors. So from the 2014 onwards, ever since I came to Gurgaon or Delhi, I thought that we need to also have a little bit of discussion with doctors around how to promote health and look at some of the health topics. So we had our first ones in 2015 with alcohol-related diseases. I was fortunate that Dr. B.N. Tandon was alive. He was my teacher and mentor. So he inaugurated. We had IBD biologicals, one of those in 2016. In between, we had Eco Summits, which was on probiotics. But the one which we have now been consistently doing for last 6 years have been the NAFLD Conclave with sponsorship from Zydus. And this has been going well. The first year we had just about 100 odd people, and I think that tomorrow you will see about more than 400 physically, which is a big event. We have a series called G-Talk. This is basically talking to physicians and introducing them to the concepts of what is the cutting edge in gastroenterology and hepatology. So some of my colleagues here, I can see Manav and others, Ashish, they have been part of it. And the GEM program is a very unique program. This is a program, this is I think the 3rd or 4th year, we did it just 2 weeks ago. This is on mentorship and career building program. And this is a platform for young people to tell what are the problems they face when they want to actually rise in life. And earlier on, we were the big dads telling them how to succeed in life. But now what we realized is that the challenges we faced were 40 years ago, and time has changed. So now we have changed it into having the middle level people, say a chap like Amit, telling what are the struggles of getting a faculty position and doing work in a government institute. It relates much more to the younger crowd than what Dr. Koshi or I would be able to tell them. So this is the way it's going. It's getting a lot of attraction. The last slide is that, because we have to cover a lot of ground today and tomorrow, this is the slide I project every year to remind the speakers that if you can't explain it simply, you don't understand it well enough. So people who give very long talks are usually confused. So when I asked Arun Sanyal that how much time do you really need for your talks, he was upfront and he said that 15 minutes. I said, but you're coming all the way, is that good enough? He said, yeah, beyond 15 minutes most people start dozing off or going into daydreaming. So that's why I think that we have kept the talks short. Decide in your mind what are the messages which are important and convey it with clarity and leave a lot of time for discussion. So that would be my advice to all the faculty who would be presenting. That's all from Hope Initiative. I have the pleasant task of inviting a few people on dais just to introduce them to you. Earlier on I used to do too much by myself. Now I have actually created groups who help me, and amazingly, a lot of people are willing to help. So I have a fairly large organizing committee. So may I request my organizing committee members to come up? So I have Dr. Ashish Kumar, Dr. Manav Vadhavan, Dr. Neeraj, Dr. Kaushal, Dr. Rinkesh Bansal is my colleague, and we have two young people, Arun Valsan and Akash Roy. Are they there? Yeah. And this experiment in GEM worked wonders. So I wasn't the chap coming and popping my head up every now and then to say time is up. They were doing it and doing it much more gracefully. And they were also participating in a big way. And also it gives them a chance to kind of get to know everybody. Please come. Okay, so these are the people you can touch base for anything that you need. Of course, you have the huge group of Zydus people around, and they'll always be there. They have been very big support and sponsors, but I thought that I must say a special thanks to all of them. They'll be here. The next thing I would like to do is to pictures taken. After that, you can be on dais if you want to have your pictures clicked with more senior people. You don't want to have it? So, Dr. Abraham Koshi, your market value is going down. So, may I have the privilege of inviting one of my teachers? Very few are alive now, but Dr. Abraham Koshi, he was the faculty at Lucknow when I joined as a young faculty. Please come, Dr. Koshi. And he taught us at that time the Lotus spreadsheet. I remember we were very difficult students. So Vivek and I, we were learning. So Abraham Koshi sir is a person who has been one of those towering people in the field of academic hepatology and gastroenterology. I have the pleasure of inviting him here to honor him. May I do the honors for him? Where's the... Dr. Koshi, you will have to take it from somebody less senior than you. That's me. Okay? So, but after that, I'll pass it on to you. And Arun, you are here. I mean, you are, of course, closer to me in age, but in stature, you are much higher up. So, why don't you come up? A big round of applause for Dr. Arun Sanyal. For those of you who don't know Bengalis, they usually start off greeting each other with a fight. It's usually a mock fight. So if you notice the way he entered, the first thing he said, I am not coming again like this. You give me notice, such a short notice, and I have to come for 48 hours and go back. I'm never doing this again. That's the usual way he always does. But anyway, we look forward to welcoming him each time. Thanks a lot, Arun, for coming. Arun, just hang on for a while, just a bit. Just be right there, stand right there. Now may I request another very senior person to come up. I've learned a lot from him. That's Professor Narendranathan. Dr. Narendranathan was a very bright faculty member at the Trivandrum Medical College when I was just a lecturer, and I learned so much from him. A brilliant researcher, brilliant teacher. Dr. Narendranathan, it's a privilege to have you, and we would like to felicitate you. He's one of the sharpest minds. More than the mind, he's a very sharp critic, and he's pretty unsparing in his criticism, but he doesn't offend. Okay. Now we have a few other senior people coming up. Dr. P.N. Rao, may I request you to come over? Another person with whom no liver meeting in India is complete without Dr. Rao. Go ahead, felicitations. Then we have Dr. K.R. Palaniswamy. I mean, he's been a doyen in not just Tamil Nadu, but all over the country. He's been the president of ISG, and a very great amount of leadership quality that he shows. Dr. P.N. Rao, just stay back, please, if you don't mind. You know, this honoring takes a bit of time. It's not like buying a train ticket to catch the next metro. So you have to give a little time and let it sink in. Thank you. We have Dr. Tarun Lahiri Mazumdar, a person who, again, in the typical Bengali style, loves to first attack before he melts. Arun has got the same traits. So Dr. Tarun was a big leader. Please come, sir. And he is from All India Institute. He went to the Middle East somewhere, then he came back, joined Manipal, then is in Calcutta. He's been one of the very ethical and very senior practitioners there, and has been a very ardent promoter of research and science. Now Dr. Premashish Kar, another person who, where are you? Dr. Kar was my senior at All India Institute. All of you know that he served for many years at the Maulana Azad Medical College as a big academic. And at the moment he is practicing in Delhi. Done a huge amount of research on liver. If any of you don't like the color of your shawls, you can exchange it between yourselves. Okay. The only one I chose was the one for Arun, because I thought it will match his complexion. And now we have Dr. Ashokanand Konar. Are you there, sir? The problem with him is a very quiet guy, but the fact is that his knowledge of hepatology is fantastic. The second problem with him is that if I have to send a patient to him, it's almost like sending to Parimal Lavate. You don't get an appointment for 3 months. Okay. Thank you, Dr. Konar, for being here. Dr. Chawla, are you here? I didn't see him. Dr. Chawla. Actually, Dr. Chawla has been my senior and mentor along with Dr. Subrat Acharya, and it's a pleasure to have him. Incidentally, his wife has assumed the role of a spiritual guru for me, and she's very widely read, and she's into a lot of spirituality. Yeah. All of you know that he served as director of PGI Chandigarh, and he's been a brilliant hepatologist. His student now, Dr. Dhiman, who was also my student, is right now the director at SGPGI. And Dr. Ramesh Rooprai. I can't help but pull his leg. I can pull his leg now because he's got his knees replaced. But the fact is that he's been much older to me in years, but he's younger than me in doing his DM. So I've had the privilege of actually once in a while being tough with him, because I finished my DM in 83 and he joined in 83. But it's a pleasure to have known and worked with Dr. Ramesh Rubrai. He sings very well. Thank you so much for the felicitations. Now may I request all of you to kindly just come and light that lamp. You people are the big experts. No, please. Many of you who have not yet been felicitated this time, please don't lose heart. It only means that I don't think that you're old enough of a vintage quality as of now. So next year your turn is likely to come, okay? I can see some people looking with envy. Probably S.C. Anand would be one and so on. Duseja, you are much junior, so at the moment you can sit quiet. So your turn will all come, okay? So now the next thing to be done is that, are you enjoying the ambience and coming here and being together? So whom do you think we should thank? GC, when I retired from SGPGI, I had no money in my pocket. So so you need people who need to support a cause. And may I now request Mr. Desai, is he here? Samir Desai, and his team, that is Sanjit and Parul, to come up on the dais. They are the people, they for some reason, I don't think it was for love for me, but it was probably their sense of dedication to fatty liver disease that they decided to embark on this journey. And it's been going on for a while. Sorry, Kannan, I missed you out. Come. And all of you. And may I request Mr. Samir Desai to come and speak a few words. A big round of applause to them. They are the ones who made it all happen. Before I give it to Samir, I must tell you one more thing. It's been a bit of a tussle. You have read the book, The Argumentative Indian. We are all argumentative. By the way, it's written by a Nobel laureate. Guess who? The fact is we love to argue, and we have had long arguments that although you're the sponsors, what should be the role that you should have in a scientific discourse? And I must place on record my appreciation that they have stepped back and supported the program without necessarily making it into a very gaudy kind of a carnival. And I really hats off to them. And Samir, over to you. Please come and say a few words.
Good afternoon, and we should begin with the scientific session soon, so I would try and keep it as brief as possible. Dr. God Chaudhary is a smarter salesman than most of us. He's already committed Lifetime Achievement Awards to some very young people, so he's kind of made sure that we'll need to continue to support this initiative for a very, very long time to come. But thank you so much. I know with every other weekend having some or the other meeting, it's not easy for all of you to take out this time and be here with us. I must also place on record our most sincere appreciation for Dr. Gaurdar Chaudhary for having shepherded this initiative for these 6 years and hopefully for a long time going forward. And I must also thank Dr. Arun Sanyal, who's been the chief patron, I should say, who's been pushing us, goading us, guiding us, and has always made it possible, even if it is for a very, very short visit, coming at a short interval after your last India trip as well. But you've always made it possible, sir, to be here and, share your wealth of experience and knowledge with the rest of, gastroenterologists, hepatologists of the country, and this is really very sincerely appreciated. Once again, thank you very much, everyone, for being here. Thank you.
Good afternoon. So after this felicitation ceremony, we would begin with the scientific sessions. And I would just mention what Dr. Chaudhary always said. I was his student at SGPJ, that you have to be brief. So as Dr. Chaudhary mentioned that in his lecture, that it's a request to all the speakers that you have to convey your message in brief, do not exceed time. So this is all my submission to you. So for first session, which is the state-of-the-art lecture, I would like to invite the chairpersons for this session. I would request Dr. Abraham Koshi to come on the stage, Dr. B.V. Tantri, Dr. Shobhna Bhatia, and Dr. Rajesh Puri. I request the chairpersons to introduce the moderators for the session, who would be Dr. P.N. Rao and Dr. Parimal Lavate, and also to invite the speaker for this session, who would be Dr. Arun Sanyal. So I would hand over to Dr. Abraham Koshi for inviting the moderators as well as the speaker.
Thank you. May I invite Dr. P.N. Rao? He is from AIG Hyderabad, a very senior person, primary interest in hepatology. And Dr. Parimal Lavate. Thank you.
Introduce the speaker.
May I invite Dr. Arun Sanyal? Arun Sanyal is a very exceptional person. He started in India. He's been a teacher. He's been an entrepreneur. He's received the highest accolades from the associations, the liver groups, hepatology. He's been the president of the American Association for the Study of the Liver, and an exceptional researcher. And although I preceded him at All India Institute, I went to learn from him in Richmond. So here's Arun, and he will speak for himself now by giving us the exposition on NASH. Arun.
Thank you, Abraham. That's such a kind and sweet introduction. I wish my mother was here. She would have liked it. So we'll kick this meeting off this time. And by the way, in my defense, this is not counting towards my time, by the way. In my defense, if I come to India, I just don't want to come for 48 hours. I want to spend a little bit of time with my family, with my friends, and that's why I was complaining. So that's my story. I'm sticking to it. So we're going to kick this meeting off by talking about the patient journey, because that really frames all of the therapeutics and what it is we're trying to do with therapeutics. And here are my conflicts. Okay. So actually, many of you may have seen this slide in previous talks I have given, where historically we recognized that patients with obesity, hypertension, diabetes, etc., these were risk factors for fatty liver disease. But what it really is, is a comorbidity. These are comorbidities that are commonly present in the same patient. And what connects all of these different end organ diseases together is a state of metabolic stress that leads to systemic inflammation and fibrosis, which has different manifestations in different organs. And at the root cause is this imbalance between the amount of calories you take in and the amount of calories that you're able to burn, so you get increasing adiposity. So the reason this is important is because each of these organs represents a competing threat to life. And we have to start thinking about the patient more holistically, rather than simply as a specialist who treats organs but not the patient. So, a quick question here. I was told we needed to have questions. And I think there's some voting pads out on your desk. So you can read the question here. How are most patients identified? Abnormal ALT, imaging, symptoms, routine screening, or by accident? Let's see what everybody thinks. Wow. Let's see what the poll says. Okay, well, actually, the truth is that the majority of patients are identified by accident when you're not looking for. When you do the imaging is done for other reasons, not because you're looking for fatty liver disease. So the point of this question is really to raise awareness that we have to be aware of these other comorbidities, because if you have one, likelihood that you have fatty liver disease is much higher, so you have to look for it. So most patients at the time of presentation have fatty liver disease is diagnosed as an incidental finding while something else is being evaluated. And when symptoms occur, they are frequently nonspecific, and only a minority of people present with symptoms of liver disease. And the most common one is right upper quadrant discomfort, which, as all of you know, is a very nonspecific symptom. And fatigue is probably the most common symptom that patients will complain of. They just say they have no energy. And abnormal liver enzymes, of course, once you start looking within the population of people who have abnormal liver enzymes, after you have ruled out hepatitis C, hepatitis B, and all the usual things, then NASH becomes a sort of a leading cause of unexplained elevation of liver enzymes. But it is important also to remember that NASH can exist with completely normal enzymes. And in fact, 25% of people who have just about any chronic liver disease have persistently normal liver enzymes. So when the liver enzymes are elevated, they help you. They're really, the presence of normal liver enzymes does not mean necessarily that there's nothing going on in the liver. And of course, we also see that a lot of people are getting abdominal imaging every day for abdominal pain, nausea, vomiting, constipation, all kinds of things. And frequently, there is fatty liver. But there's so many issues. It's often not commented. The radiologist sometimes doesn't even comment on it. And if they comment on it, nobody acts on it. So I think these are all opportunities that in our own communities, we have to talk to our colleagues in radiology, make them more aware, and have them report out. But then, when they report out, we have to then figure out what we need to do next. So I want to walk you through the patient's journey in terms of the liver outcomes. So here, which is the most common liver outcome? Hepatocellular carcinoma, encephalopathy, ascites, or variceal hemorrhage? Simple question to a group of hepatologists. Really? I'm surprised. Let's see the data. Okay? So these are the data that were published in the New England Journal a year and a half ago. This is the largest data set of almost 2,000 patients followed prospectively with adjudicated outcomes. And what you see is as you go from F0 to F4, this is fibrosis stage, there's a progressive increase in all-cause mortality, with the biggest increase, of course, in those who have cirrhosis. No surprise, but here are actual real numbers. And so the mortality rate for people with cirrhosis is about 1.76 per 100 years of follow-up, per 100 patient years of follow-up. And what drives this is hepatic decompensation. And you can see once again that when you get to cirrhosis, that's when all of these decompensating events occur. Before that, it's pretty uncommon, and those patients typically get it because they have progressed to cirrhosis. Again, as hepatologists, we know this, but here are numbers. And when you look at the causes of death in this population, you can again see that liver-related mortality in a large cohort of people with all stages of fibrosis, of fatty liver disease, that liver-related mortality is a leading cause of mortality within this population, and many of whom were diabetic. So whereas historically in the diabetic population, they've always focused on cardiovascular and renal outcomes, we are now beginning to see that as they're getting better with managing the cardiac risks, many of these patients with liver disease, which takes longer to manifest as cirrhosis, are coming up and dying of liver disease. And any hepatic decompensation event actually had the highest hazard ratio for mortality, followed by cardiovascular disease, development of chronic kidney disease, and extrahepatic cancers. And when you look at the decompensation event, what you're seeing on the left is the cumulative probability of developing a problem. So if you look at the two top bars on the left graph, the orange one is after decompensation mortality, and the blue is the same cirrhotic patient before decompensation. So what it really tells you is the tremendous impact that once you decompensate, that has on mortality. So our goal is really to prevent that decompensation and actually progression to cirrhosis, but with the eventual idea that you are preventing decompensation. And this can also be identified by a FIB4 test. And as it turns out in this study, encephalopathy is the most common decompensating event, followed by ascites, and then all the other things follow, and hepatocellular carcinoma. At least in the West, variceal hemorrhage has become much less common than it used to be. Part of it is because I think we have become much better at primary prophylaxis, and we just don't see, in fact, in many places, there's a lot of concern that the fellows who are in training are not doing enough to be really facile, whereas, back in the day, it was literally every night we had to come in to scope a variceal bleeder. Now, all of this is based on histology, but this paper is just accepted 2 weeks ago, and this is a prospective study of 2,500 patients, approximately, and where the patients were classified on the basis of FIB4. And we look at FIB4 less than 1.3, more than 2.6, and in the interim. And you can see there's a stepwise increase, but it's exponential when you go from less than 2.6 to greater than 2.6. And you can see similarly a big step up in liver events, cardiovascular events, and hepatocellular carcinoma. And I think, Ajay, for the ICON cohort, this is the study that needs to be replicated to see whether it tracks. Furthermore, we now see that fibrosis regression is associated with reduction in events in patients, even in patients with cirrhosis. So this is a study, 2 studies. We had about almost 1,000 patients with cirrhosis who got 2 biopsies 1 year apart. And to our surprise, we found 176 on the second biopsy no longer had cirrhosis. And most of them were F3. So I suspect there was a lot of argument whether this is sampling variability, that how can cirrhosis go away, especially if you have not done anything specifically therapeutically for the patient. But what was remarkable is that in these patients that had less fibrosis on the second biopsy, they had an 85% decrease in clinical outcomes. So the actual events were decreased by about 85%. So for what it's worth, This data is now published, actually, and we presented it originally in 2020. Now, we talked about not thinking about just the liver in these patients. So we need to look at extrahepatic events as well. So if you look at the incidence of events, the mortality goes from 0.32 to 0.89 to 1.76. So per 100 patient years of follow-up. And as you can see over here, variceal bleeding was pretty uncommon. Ascites, modest, and encephalopathy, numerically the most common, and then followed by rising MELD. And this was driven in some cases by chronic kidney disease, because many of these patients are diabetic and hypertensive for many years, and creatinine is part of the MELD. And when you combine all the liver-associated clinical events rates, it jumps from 1.54 at bridging fibrosis per 100 person years of follow-up to 4.46 per 100 person years. This is very important because when you design trials, when you look at outcomes, this is the benchmark that you have to beat. So you have to bring the numbers lower than this. And then, of course, what was remarkable is that if you look at hypertension, the rates for the liver events are 2s and 3s and 4s. It's 14.4. And historically, when you look at cirrhotics, we think cirrhotics are these vasodilated people walking around with a systolic blood pressure of 90 and their mean arterial pressure is 55. But here we are finding new onset of hypertension. This is incidence, not prevalence. New development of hypertension, even in the presence of cirrhosis. So everything you learned with the alcohol patients and with the hepatitis C patients, this is a different beast. You need to relearn what cirrhosis looks like in these patients. And followed by decline in eGFR, which, as you can see, is almost as common as total liver-related clinical events. And then diabetes is, of course, new onset development of diabetes, also quite high. So the further along your liver diseases, the further along all the other end organ diseases are, because they all have common biology that is driving all of them. And these are the data for chronic kidney disease. And you can see over here that there are different thresholds. And this greater than 40% decline is really an important one, because this is a very good surrogate. If you have 40% decline in eGFR, that's a very good surrogate that you're going to end up on dialysis. So this is a marker of bad things that's going to happen down the road. And this is actually a regulatory approval cutoff for development of drugs for chronic kidney disease. So remember that number. The other thing that is highly overrepresented in this population are gallstones. And there are a number of reasons. This is an obese population. We showed many years ago that there's increased cholesterol synthesis in the liver. And much of that cholesterol, some of that cholesterol gets excreted into the bile. So on the one hand, the cholesterol goes up. Number two, there are these bile acids called deoxycholate, which increases, so that slows down bile flow. And the ability to form micelles. So this mismatch leads to supersaturated bile, which can lead to gallstones in this population. We're also now learning that even before cirrhosis, there's progressive neurocognitive dysfunction and decline. And this is now becoming a real thing where people are talking about Alzheimer's disease being part of this metabolic syndrome spectrum. And it starts much earlier. So it's not hepatic encephalopathy. It is actually primary neurocognitive dysfunction. So as we think about encephalopathy in the context of NASH cirrhosis, we really have to also start generating more data around the progressive background neurocognitive decline that occurs in these patients to see how much of it is attributable to the liver and how much of it is attributable to something else. Young women who have this suffer a lot because frequently there's a strong correlation with polycystic ovary and infertility. And so many of these ladies struggle with reproductive health as they go along. So these are all things that have to be paid attention to. And lastly, talking about cancers, it's no surprise that when you have advanced liver fibrosis, that's the population where you get liver cancer. But really, the stage of disease does not impact extrahepatic cancers. And this has been shown by a couple of other groups as well. And the hepatocellular carcinoma that occurs in these patients, there is a specific form. It's frequently also referred to as steatohepatitic hepatocellular carcinoma. It's frequently solitary, well-differentiated, but has increased biliary invasion. So some take-home messages: fatty liver disease is common. It should be suspected in anyone with excess adiposity or with features of metabolic syndrome. It should be routinely reported in imaging studies. There's a distinct clinical profile of people with severe fatty liver disease, especially those who have advanced fibrosis. Progression to advanced fibrosis is the key driver to liver outcomes and can occur silently, and you cannot rely on liver enzymes. The AST to ALT ratio and FIB4 are simple tools for assessment, and in your clinic, in the care pathway, if there's one message to take home, is check the FIB4. If it is less than 1.3, very little is going to happen to the patient in the next 5 years. If it's more than 2.6, you better pay close attention to that patient. Thank you.
Thank you, Dr. Sanyal, for finishing well before time. And we did not include that 1 minute that you took extra. But I had a simple question. You know, we all do fibro scans when patients come on with AST, ALT that's elevated, with an ALT more than an AST. But is FibroScan all that reliable? Because I've come across a couple of patients who have elevated AST, ALT for a long time, but the FibroScan is clean.
So I think FibroScan has many of the same problems as the FIB4.
Okay.
It has a very good negative predictive value. So if the liver stiffness is normal, then I think you can be pretty confident that everything is good. Okay. On the other hand, if the liver stiffness is up, you really don't know because the positive predictive value is not very good. The second thing is, unlike FIB4, which is, you put the blood into the machine and the machine does all the work, and machines generally do it more reproducibly than human beings.
Yes.
With FibroScan, sometimes it takes 10 seconds to get 10 readings, and you're 100% confident that you got perfect readings. Sometimes after every 2 readings, it says you get this no signal, and then you have to play around with it. Then you're not so confident that, you finally managed to get the 10 readings with the less than 30%, IQR, but
yes.
Then you're not so sure whether it's really. So I think that it's a little more noisy in that respect.
May I ask a question?
Sure.
Very well, sir. Thank you very much for the presentation. Beautifully, you presented that data of CGH. I just want to understand, as there is 15 to 20% of patients with fatty liver disease are fast progressors. So do we have any data? What are the predictors, specifically in this large data set? Who are the patients who are...
Yeah, that's a great question, and we've been looking very closely for this. Unfortunately, we have not found a clinical biomarker. I cannot tell you if your FIB4 is more than this or if your FIB4 changes. We published a paper looking at changes in FIB4. It's not very good for monitoring people as a disease monitoring tool. It is very good for one-time assessment of prognosis, but to track the patient, a lot of fibrosis has to change for the FIB4 to change. The other caveat with the FIB4 is do not check a FIB4 when the patient is in the hospital with an acute illness and their liver enzymes are all over the place. You need a stable, baseline to check the FIB4. So we have not landed on exactly how to identify. Maybe there's going to be a combination of genes, that PNPLA3 and other things, but I think we don't really have a good answer to that question at this point. But it's a very important question.
Yeah, just I have a small comment on that question. Today morning we had, Raj Mukherjee and Karen Thompson visiting us in the department, and Karen works in this cognitive and neurodysfunction in NAFLD. And she actually told us about something like the defect in the urea cycle, which is, very peculiar to NAFLD or maybe fat in the liver, and that's probably responsible for this neurocognitive defect. So I think probably the work is still on. So that is what we were discussing in the morning. And the second was about, in your paper last year in NEGM, where you had shown about the prospective follow-up of patients, and where you had shown that if if you look at the extrahepatic outcomes, maybe the cardiac events, and maybe the cancer outcome, there was no difference as far as the stage of the fatty liver disease is concerned, which actually means that F1 or F2 would be as important if you're looking for, say, extrahepatic or events. When it comes to liver, yes, F3, F4 becomes more important, but I think in the beginning, probably they are responsible.
Oh, absolutely. I think the neurocognitive thing is a very interesting story. And in NASH particularly, the mitochondria are damaged. And mitochondria is where the urea cycle is. But I don't think it is a simple function of hyperammonemia. We've actually looked at that. I don't believe that. It's much more complicated. There is neuroinflammation. There's a lot of data on neuroinflammation, and TNF and several other cytokines seem to play a role in that. So there's a lot of work going on in that space. And you're absolutely right that cardiovascular did not change with but part of it could be because we are so tuned to cardiovascular disease risk in NASH that in the NASH Clinical Research Network, which is 8 academic sites, everybody is always looking at the cholesterol and making sure everything is managed in a very rigorous way. So it may be the truth in a real world setting may be different. I don't know. But we think that's part of the reason. The other thing is you're absolutely right that we should start thinking about cardiovascular risk right up front. So in the early stages of the disease, it's a cardiac, the principal outcomes are cardiac and metabolic. But it's only when you get to bridging fibrosis that the lines start crossing.
As usual, we enjoyed your talk again every time. I just wanted to ask you that in the cardiovascular risk, which test would be very useful to investigate that particular patient with NAFLD2, that this patient is likely to go further in the cardiovascular risk?
I think there are two things that I think are first thing, family history of cardiac events. That's a simple cost nothing kind of test. Number two, LDL cholesterol still is the leading biomarker for cardiac risk. If you want to be if you want to look at the myocardium, you can look at BNP as well. But certainly not to do an LDL cholesterol on someone with fatty liver disease is malpractice in my view. And, and then lastly, the coronary calcium score, which has a very strong predictive value for actual events. So a CAC, along with the LDL cholesterol, gives you a pretty good readout on what's going on in the heart.
Thank you. Yeah.
That's till tomorrow afternoon.
We have a whole session on cardiovascular disease.
So let's not ask all our questions right now. Poor chap has just walked in 40 minutes ago, and you could hear him grumbling about his tight schedule. So we'll eat him up piece by piece.
I was not being grumpy about my tight schedule. I'm grumping about your timing of the meeting. Your planning, your inability to plan ahead of time. Okay. That's a different thing.
We'll fight it out over drinks and dinner today evening. Okay?
Yes. So thank you, Dr. Sanyal. I think it was a wonderful session.
Thank you. Thank you.
Arun, just a minute. There's a small memento for you.
Oh.
That was intentionally withheld when we gave him the shawl, because this is after his lecture. All of you can come together for a quick picture. For those of you who are feeling a little awkward, don't feel upset. Bengalis are used to fighting, but that's actually a sign of love. I think other people should emulate us. Thank you so much, chairpersons and moderators. We move to the next talk. This is by another brilliant Indian hepatologist. I'll leave it to him to make the announcements, please.
So the understanding of any disease centers around understanding its epidemiology, and in medical science, perhaps there's one disease which has seen a sea change in epidemiology is possibly non-alcoholic fatty liver disease. To chair this session for epidemiology of non-alcoholic fatty liver disease, I would like to call upon stage the chairpersons of this session, Dr. Sandeep Pandey, Dr. B.S. Rana, Dr. Harsh Kapoor, Dr. Sameer Taneja, and Dr. B.S. Satyaprakash. I would request the chairpersons to introduce and call upon stage the moderators for the session.
It's indeed an honor to be chairing a session when someone like Abhijit Chaudhary is talking on the epidemiological similarities and differences across India. It's a new topic. I request Dr. K.R. Palaniswamy, who has been honored today, and Dr. Prema Shishkar to come and moderate the session. And simultaneously, I request Dr. Abhijit Chaudhary to come and deliver the talk. Dr. Abhijit Chaudhary.
May I have my slides? Okay. Thanks, chairpersons and respected moderators, and thanks, Gourda, for this brilliant get-together, which we keep on getting almost every year. And the ask that I have been given to is, I've written here in India, but let me tell you, I've been asked, and I will tweak it across the India, and obviously it's not going to be, I'll try to do whatever ability I have to see the way it, there are similarities, and there are, and differences, the way it has been presented before me. So as we know that epidemiology as such had been mostly an exercise based on mathematical data and statistical correlation of associations of those data with an intent that researchers as well as policymakers can harness their dividends out of that. So with that intent, usually whenever we talk on epidemiology of NAFLD, we keep on telling that this big a problem or this small a problem is epidemiology in India. Let me tell you, I'm going to tell you in the next 15 minutes or so, not only some data, obviously I'm going to depend on data, I'm going to try to understand myself and share with you the way these data have got micro differences apart from the macro similarities that it has got across the country. So first, the very first picture that I present is a paper from Shalimar's group, which was published in JCEH, I think last year, which shows the amount of diversity and heterogeneity. You see on the left-hand side is the average risk adult prevalence of fatty liver disease in India. It has been averaged as a whooping 30% or more in India. But you see the forest plot shows the amount of divergence that is present in the data set, telling us that there had been multiple different approaches across the country in assessing, in trying to assess the problem that we have got right now. And on the right-hand side is the high-risk adult, which is obviously high. I'm not going into the figures. It's pretty high, but what's the exact figure is really $1 million question even today. But interestingly, as I was trying to prepare for this talk, I was trying to figure out how, epidemiology and liver disease prevalence research has gone on over the PubMed. And on the left-hand panel, you can see that there had been significant increasing number over the last couple of years on the number of liver disease prevalence studies across the country, and liver disease population studies across the country. And the liver disease NAFLD population studies have also shown increase, but not that high over the last couple of 3-4 years or so. But on the right-hand panel is the figure that Orko De and Ajay Duseja published in, I think, Clinics in Liver Disease last year, where you can see, this is a graphical depiction of the divergence and divergent figures that are across the country. In the East, we reported almost 9%. I'll show you some new data. And across other parts of the country, down south, you get a figure of almost 50%. Why is this difference? And where does truth lies? This keeps on hitting my mind as it keeps on hitting you. What's the true figure? We yet don't know. I'll come again on the values of that. Again, this variety of divergent data is all across the country. So heterogeneity of available data based on whatever quality of studies or the way it has been counted is well known. But one thing is pretty clear, that epidemiology of fatty liver disease is driven, as already discussed, by obesity and adiposity. We all know that it's all dysfunctional, inflamed adipose tissue, wherever it is, that drives the inflammation and metabolic stress, as already been mentioned, in the liver, that finally drives metabolic liver disease. And we also know that we cannot really look, as Professor Sharnal has just mentioned, fatty liver disease from a tubular vision, only liver angle, and it's much more greater metabolic ill health as today being perceived. And we know that the prevalence of overweight on the left-hand panel, in the prevalence of fatty liver disease in the overweight is almost 70%. And on the bottom panel, you see, India has been shown to have a overweight prevalence and fatty liver disease prevalence in overweight of more than 70%. And this is near to US figures. And this is based on this is a meta-analysis of data. And the other entity that we also keep on discussing is fatty liver disease in the lean or non-obese people. And there are other data also. Why I'm telling is there is significant amount of data noise and data, clouding. And we need to come to points, what's the primary situation to have a macro view. The fatty liver disease in lean people is also fairly high. And some studies, and this Lancet paper has also shown it's more than 40% or so global population prevalence, and in many parts of the country is fairly high. But the issue is that, and we recently looked at our population-based data. As you know, we work in the Birbhum population cohort. It's a fairly captive cohort which you had been following. And this is a recent data which Kaushik and Shouvik are working on. And we are struggling to figure out that our data still hovers around in the community cohort of almost 7,000 people who had been studied by ultrasound and transient elastography. And one of the questions that came from Shobna about the FibroScan usage. And let me tell you that Indian fatty liver disease is almost synonymous with FibroScan detected fatty liver disease. I beg to differ. And if this is confusing, this is creating even more confusion. And transient elastography is possibly the one that Professor Sharnal was also mentioning. But today we get a FibroScan value in a piece of paper, which is all non-standardized and whatever method has been used. So we are probably not being able to equate the values of each of these things. And this should be one of the objectives of one of the forums of us. So in our study in the community cohort of 7,000 people in Birbhum, free living population, which is mostly again non-overweight, non-obese, 70% non-obese, we found a prevalence of 7% based on ultrasound more than grade 2 fatty liver done by 2 individuals, which is pretty low. Now, we did other things also. We did in the tertiary care cohort, we did biopsies of those people who came with a diagnosis of fatty liver and had elevated ALT of more than 2 times upper limit of normal. These are the people who came like that. And we also tried to dig in a bit deeper by doing insulin resistance and other studies I'll show you. But interestingly, and what intrigues us even today, that we really did not find a great high incidence of significant fatty liver disease. So non-NASH NAFLD in these people who are coming with fatty liver disease was almost 45%. Definite NASH was present in a very small fraction of this fraction of people. I'm yet to go deeper into the data, and we have been struggling with this data, but I'm not sure. But NASH cirrhosis was present in 5% of those people who came to us with fatty liver disease. This is almost 284 biopsies who had been done consecutively over the last 2-3 years. And this is what I showed you, telling us that we had mild disease in the majority. Large proportion did not qualify as NASH. These are the people who came with a fatty liver on ultrasound, grade 2 more than that, and had an elevated ALT. So is our disease different, or or the way we approach the study is different? That's a question for us. Now, what we did is we tried to look at the insulin resistant by frequently sampled IVGTT in 92 of these people who were biopsied, 274 people, and did find that both insulin resistance and beta cell function really did not differ based on whether the patient had non-NASH NAFLD or definite NASH or indeterminate NASH, and between obese and the non-obese cohort. Again, needs more detailed look into. So the question is, why I mentioned this in epidemiology is, when you do liver disease epidemiology, you need to look at the prevalence of the primary entity, and in a condition like fatty liver disease, we also need to go into disease epidemiology, and disease epidemiology means presence of fibrosis, presence of cirrhosis, and I think when insulin resistance is such an important component of mechanism of fatty liver disease, we also need to figure out, and that's a very important need of the call of the hour is what is the status of insulin resistance in our population. And I think, given the fact that insulin resistance is the primary driver in Indians, and South Asians develop fatty liver disease and the metabolic ill health at a different body mass index criteria and all those criteria, I think we need to look at our insulin resistance genetic factors, pathogenetic factors. So that's it. So what are the reasons of heterogeneity and data noise? So first question is what you measure. Unfortunately, even today, we don't have a biomarker of fatty liver disease, as had been clearly mentioned. Lot of endeavors are gone, but you don't have something like a viral marker or something like that to tell you. And we all look at the elephant almost blindfolded, keep on improving our attempt, but only to realize at a later point of time that ours was less than precise what we wanted to hit at. So that's one of the reasons why what is different when we think back. How you measure. So, the epidemiological data that has come, some are ultrasound-based, some are MR-based, some are CT-based, some are biopsy-based. And that's one of the reasons why this amount of heterogeneity. Very importantly is where you measure. Most of that study which had been mentioned here were not really population-based studies. And even if it is mentioned as population-based, were referred population-based, select population-based, hospital-based data, blood donor data, and general population-based data will obviously, and did not have the diversity like rural-urban and all the micro-diversity figures that we need to have in this country. Because this country is that mosaic structure, as I'll soon mention. And very importantly, how you analyze. As you know, statistics is all how you look at it and integrate the available data. So all these figures, I think we need to look at if we really want to come to a conclusion about the heterogeneity of the data set that we have, which is really paining us. So now I'm going to take you a broader picture of metabolic ill health in general, and fatty liver disease, as I mentioned, and as Professor Shannal mentioned at the very outset, cannot be looked at from a liver vision only, and much broader, and there are other associates which gives us more objectivity, more precision and information in this country to look at the regional and local regional diversity. So this is the prevalence of metabolic syndrome in India. As you know, metabolic syndrome is much more objective because it has got defined criteria. But even then, you see the dispersion of data that is in this meta-analysis. Huge dispersion. It's more than 1/3 of the population of the country is thought to have metabolic syndrome. But again, it goes to 70% and it goes down to less than. Reasons are the same, the 4 points that I mentioned to you. Interestingly, NAFHS, National Family Health Survey, had been giving us data over the almost 10 years. So the first one was 2005, next one was 2015. This is the questionnaire based and more of a less than perfect data for using in biological studies, but good data for planning. One thing is very clear, on the upper left-hand panel I have shown that the percentage of overweight and obesity in India is progressively increasing. We all know that. And interestingly, the primary epicenter for this increase are the rural areas. As you see, I have earmarked on that, the rural, from 2005 to 2019 and 20, the rural shows a much higher jump compared to the urban jump in prevalence of overweight and obesity, because without overweight and obesity you really cannot have. Interestingly, even if you disentangle the data and decompose the data into socioeconomic status, you see that no education, primary education and secondary education, NFHS data, it's a very interesting data set. And the poorest and the poorer and the middle have got the highest increasing, progressive increase in the prevalence of obesity and overweight that's happening in the country. Now, if I come to, even decomposition of the data based on NFHS data, you see different India. And we all know India is really not a single country in terms of, and big differential slab in India. We are in a big nutrition transition. So on the y-axis, you have got prevalence of underweight women. And metabolic syndrome, let me tell you, is more in women than in men in the country. And on the right-hand panel, you see prevalence in the overweight women. And as you see, you have got two divergent sets of states in the country, or regions in the country. On the right-hand, bottom panel, you have got Chandigarh, Delhi, Puducherry, Kerala, Punjab, and all these states, which have got, a high prevalence of overweight women, telling us a different, socioeconomic development status. On the left-hand panel, Jharkhand, Bihar, Chhattisgarh, Assam, and Odisha, some parts of Odisha, and NFHS data, and all these. So we are really in a very differential slab of development. And this is reflected in every disease that is linked to overweight, nutrition transition, and epidemiological transition that we are currently having in the country. And that's the reason we are having different data across the country. One of the best data sets that I could look at is the ICMR in DIAP data sets. We don't have such a good data set for fatty liver disease. I think we can draw our understanding from here, and that was a very meticulously sampled population. I'll show you that, and we need to learn from that. And that showed that diabetes in India, its overall prevalence is something like 8%. For me, that's not interesting. Interesting is that it follows GDP differential across the country. And so, from the left hand, you see, from Bihar to Chandigarh, Tamil Nadu, Punjab, and all these states, progressively increasing incidence of diabetes in the ICMR INDIAP data set of 15 states, and which included almost 14,000 very strategically sampled population. Now, if you come down and if you break down that into micro data sets, you see that in a couple of states where more progressive urbanization is taking place, like ICMR, like Chandigarh, Punjab, Tamil Nadu, and all these countries, it breaks even the socioeconomic barrier. And the urban poor are the primary abode for the increasing incidence of diabetes in these countries. This is, again, a fascinating data, but look at the way they did it. They did it in 15 states across the country, both rural, urban, went to villages and urban wards, and then, their ways they did the meticulous sampling in the rural areas and the urban sampling areas were different. And, if we really want to have some data on fatty liver disease and linked metabolic conditions, we need to do it in this way. Otherwise, I do it in Calcutta, somebody does it in Chandigarh, somebody does it in Chennai, and we finally collate and do an average, and that really does not give a representation of what's the differential in the country. We recently did a composite metabolic ill health data and try to understand how we can improve on, and that got published in Lancet Regional Health very recently. And I just thought of sharing that with you. We had a large population in Birbhum. The target is almost 110,000 population. We could approach 80,000 population. That was a 3 staggered approach. We initially did a anthropometry and all those studies, then did ALT and random blood sugar, then did ALT and so sequentially, stepwise, incrementally, we went on to figure out how many were metabolically unhealthy and have got potential to have fatty liver disease in this population. And on the initial screen, if a person was found to have everything good, we gave him a green card. On the second analysis, if the person was found to have bad, we gave him a yellow card. And if the person is found to be really metabolically unhealthy, with bad lipids, with bad fatty liver, with elastography, HbA1c, and all this, we gave him a red card. I mean, this is just trying to devise a model of how metabolic ill health can be approached in a composite manner, not looking at only from a liver-centric approach in this country. And I think we can have many such approaches, but this country needs a non-ultrasound-driven, purely ultrasound-driven, non-fibroscan-driven approach. And that's too mathematical and too reductionist, I think, for a country with that much of heterogeneity in this country. But now I come to something which is really not mathematical. It's much more qualitative than we get in the quantitative figures. So I just propose here, and we all know there, that we need to understand that fatty liver disease is a socio-behavioral disease, as Gaurda mentioned at the very outset. And unless you can impact on that, and you need to understand the crevices in the behavioral paradigm, you really cannot make an impact on that. So let's talk more about the envirome than talk about the biome, metabolome, or microbiome, or genome, what we keep on talking, which is necessary. But that's not everything. It's like the story of PAMPs and DAMs. PAMs are the environments, and the dams are what we are keeping on in influencing the obesity, metabolic ill health, and steatotic liver disease matrix. And let me tell you, the word called steatotic liver disease is very much on the offing, and we are going to, we need to understand that. So how does that happen? This is again NFHS data. And let me tell you that how do Indians eat? And as you see here, I just focused on two things. One is we are eating progressively less dark green leafy vegetables and less any protein, and almost no eggs and no fish. This is country's data. I'm not going to the micro dissection of the data, but this indicates that studies into nutritional things need to take in, epidemiology of nutrition in this country need to go more detail. Interestingly, we studied in Birbhum again, in our population cohort, what's happening in the, the behavioral changes. And between 2009 and 2017, the cell phone usage has gone like skyrocketing. And the motorbike riding and alcohol, this is a rural population cohort, as you know, has gone like this. So, the country and the country's populace is in a pleasure hunt. And I think the metabolic ill health is a product of that. We need to look at that also and change the behavior. Now, interestingly, again, India presents a mosaic of growth. Subnational differences are tremendously profound. And national policy, how national policies get translated in other countries, in states, is very important. So on the left-hand panel, you have got, figures of urbanization and poverty headcount ratio, which is very important from a socio-economic point of view. And as you see here, there is a big differential. And urbanization and poverty headcount ratio, more urbanization, less is the poverty headcount ratio. And on the right-hand panel is even more important, which excited me. India is undergoing a tremendous structural transformation. We are going in a differential pace, in a transition and transformation from a subsistence agricultural driven economy, which is still prevalent in many parts of the country. Each of these dots represent one state, and the y-axis represents the primary agricultural driven states, and the x-axis represents the modernized economy driven states, exemplified by, say, Chandigarh, by Goa, by Hyderabad, cities and all. So the pace of this structural transformation that is taking place, which has got some quantitative component, but very important qualitative component, will determine how metabolic ill health differs across the country. So if we analyze this analytical dynamics of this epidemiological diversity of metabolic ill health, how does it come? And this is what, I tried to synthesize myself. You have got some stressors, which are biological. You have got an obesogenic environment, you have got an obesogenic behavior, and you have got a macro environment, macroeconomic or social environment. 4 things we can put. And we initially had obesity and all these ill healths focused in the reach only, in the early phases of metabolic ill health, high socioeconomic strata. The reason was that the food and economic security was focal, and all these factors were focal. There was low dietary diversity. It's a feudal society. Centricity of access was present. So the benefits of development were enjoyed by a couple of people who were high socioeconomic strata, and they were having the costs of development also, which is metabolic ill health. Progressively, this has gone to currently expanding to lower socioeconomic strata with mechanized agriculture, more and more sedentary pursuit, erosion of cultural norms with more alcoholism, and dogmas of a maturing democracy. We have got very interesting dogmas like differential growth based on political powers, utilization of resources, and regional utility trends. So there are LAP, like low agricultural productivity states, to RTS, which are rapidly transforming states. And there are some biological factors like genes, climate change, work from home features, and concept of healthiness. And all these make, a transition. So I was just imagining, we were Neanderthals. As you know, Neanderthals were the cave dwellers, and Sebonte Pabo got the Nobel Prize because he could decipher the Neanderthal to Denisovian evolution. So, initial phase in metabolic ill health was a Neanderthal ill health. So then we moved to the Denisovian ill health, and now we are in the Homo sapiens stage. And progressively, we are going down, down, down. So the next focus is on children. So finally, I summarize the epidemiological features. Based on that, India has got almost 14% of the 2 billion overweight population globally. Between 2015 and 16, it doubled, and it might have tripled by now. This has followed a trajectory, and as Gaurda told me to do, it really shows a differential of development, and this has impinged on the metabolic ill trajectory. Obesity transition begins with the rich, but now it homed in the poor. And the poor in the country are the places, rural areas, women, and shift from agriculture to non-agricultural incomes and life processes. More energy-dense foods, we all know that. The health costs of obesity, however, linked disorders are more in males, although diseases are more in females. And biological factors, I emphasize, form a nucleotic core, but the environment is finally foments and shapes how metabolic ill health and fatty liver disease is a component of that shapes. Thank you all for your patient hearing.
Thank you, Dr. Abhijit Chaudhary, for the excellent lecture on epidemiology across India. Can I invite your comments and questions?
I want to understand something. When you're talking about beer boom, you basically have a rural population. When you're doing the yellow card, green card, and your green card, yellow card, and red card, you started with nearly 80,000 people, and you've given red cards to only 470 people. So that is just what, 0.058%?
No, it should not be mathematically, deciphered. It's like symbolically telling people, it's a model. Like you can tell people by giving a green card.
I'm not talking about the cards. I'm not talking about the colors. I'm talking about people who had significant liver disease or NAFLD. So that was only 470 out of 80,000.
Yeah, because many people did not report. Many people did not report subsequently, even despite approaches. So don't look at the value of the amount. I'll share the paper with you.
Usually people in the rural, in India, especially West Bengal, they're usually farmers. They do a lot of hard work compared to the urban people. So I think obesity is still less when we look at the patients who are coming to us.
It's less, but it's increasing.
Obviously, it's increasing because of mechanized agricultural process. So you think your population is increasing. Your numbers are more, you mean to say?
Yeah, numbers are more.
Deepika,
absolutely.
I think that's a very important point, but I think that's a very important point for a discussion over chai. So we are having tea break right now. Unless it's a pressing question, we are a little behind time.
Yeah, just 1 minute maybe. Very passionate talk as always. You said there's no biomarker of fatty liver disease, we're still evolving, but there's a very good phenotype for fatty liver, and that is, overweight and obesity. Any overweight obesity person you walking into your clinic, more than 80% chance would be that he would have fatty liver disease. So just coming back to your same, the population cohort, when you started with that, and even in the original hepatology study, 70-80% of your patients are lean. You said that. And we know that the fatty liver in lean would be around 6-7%. This is the global figure. In average figure is say 30%. And when you go to the obese, it will come to maybe 80%. So I think that's the challenge, the issue here. So as your overweight and obesity will go up, so my question to you is, as 30% those who are overweight and obese, in your huge population, how many of them had fatty liver?
It's more than it was present in non-obese, but it's really not to the value of 70% that is presented in global. I cannot tell you exactly right now what was the value, but it's less than 15%, even in them. So there are a lot of unanswered questions.
I think if there are no more questions, I thank Dr. Abhijit Chaudhary for having delivered an excellent lecture, citing the differences in epidemiology of NAFLD across the country. And I think you have updated us with the latest informations, and we look forward for your further activity in this regard in future.
Big round of applause for Abhijit. I sometimes feel very much at a loss. I wish I was his student. He's a very passionate teacher. He goes very deep into the subject, and his knowledge base is very strong. Wonderful, Abhijit. One more thing I must tell about Abhijit, when you're dealing with very large population data, you can't always answer questions in very simplistic terms. And that was the mark of a researcher. You know, he actually left those ambiguous points unanswered, because you don't always have an answer for everything. But those are initial observations. He's at least made an attempt to do that. Excellent, Abhijit. I think it's time for tea. I think this is tea break. And we'll quickly grab a cup of tea and come back. I think 2 lectures are over. Now we'll go into a little bit more of a discussion mode. So the tea is a bit sugary, but our next discussion is going to be fatty liver disease in diabetics.
So we start, sir?
No, you will be announcing. I'll just make you'll be right here. Hello, can you get your coffee cups in, tea cups in? Let's begin. We are running a bit late. Is that microphone working?
Can you just give the pass?
So for most of you, I just want to tell you what is the method in madness that we have. Any scientific program is a bit of a madness, but there has to be a method in madness. So what we have done is that the first day today, we are basically focusing on only the metabolic aspects of fatty liver disease. Diabetes, obesity, diet, and so on and so forth, weight reduction. So it's primarily the metabolic part. And tomorrow would be the main part on new recent advances in the therapeutic realm. Okay? Few things, of course, brought in here and there for variety. So that's the overall design. I thought you'll keep it in mind. And after the two very erudite talks, we move to a panel discussion. And over to you. I just want to say one thing. Manav Vadhavan, I first listened to him giving a talk on fatty liver disease and diabetes in Calcutta, which was, I think, about 5 or 8 years ago. And being a kind of a academic teacher, I have this habit of spotting who's a good speaker. And from that time onwards, almost in all my sessions, when it comes to diabetes and fatty liver, Manav can't escape. So Manav is very much here with us. So over to you to make the formal announcements.
Our endocrinology colleagues believe that liver fat is just a manifestation of diabetes and metabolic syndrome. And as hepatologists, we believe that the liver is the central driver for both diabetes and metabolic syndrome. So currently it's an egg or the chicken story, but we all agree that there is a definite bi-directional relationship between NAFLD and diabetes. So with this prelude, let me welcome the next set of chairpersons, Dr. Sanjay Salunke, Dr. B.B. Gupta, Dr. Piyush Ranjan, Dr. Samir Mohindra, and Dr. Akash Roy.
Thank you, Dr. Chaudhary, for a very kind introduction. Now, what I'm going to do here is...
May I invite Professor Yogesh Chawla. He does not need any introduction. A great clinician, teacher, and a researcher, and former head of the Department of Hepatology and Director PGI. Welcome, sir. And may I also invite Dr. Manish Bhatnagar, a senior gastro colleague from Ahmedabad. Please. Okay, please continue.
Thank you. So what we intend to do here is move completely from the bench to bedside. All we are going to discuss here is how do I manage a patient who has diabetes and NAFLD/NASH. So we talk about NASH only, NAFLD we're keeping apart. We have a very eminent panel here to tell us how do they try to manage these patients in clinical practice. I have three very simple cases. I'll just give you a brief background. Prevalence of NAFLD in whatever data is published is around 1/3 in urban population. This 10% data in rural population is very old. Now it is believed to be about 20 to 30%. Dr. Desai will say that the last paper they published, I guess it was 35% in the rural area also. So we are looking at 1/3 of Indian population having NAFLD. If you look at various data from India, almost 80% of all patients who have NAFLD have insulin resistance. Frank diabetes is seen in around 15 to 20%. Metabolic syndrome in almost half these patients. But turn the page around. Look at patients who have diabetes. Again, scarce data, but more than 50% actually have fatty liver disease. And of these 50%, what is very significant is more than half of them actually have NASH, and at least 20% have cirrhosis. So of the 100 diabetics you see, 60 have NAFLD, of which at least 40 of them have NASH which needs treatment.
We need to understand the interplay of anti-diabetic medications, NASH, and vis-a-vis sugar control, and that is what is the focus. So we have been taught this slide very clearly. In managing diabetes, we have various class of drugs. The conventionals are metformin, sulfonylureas, thiazolidinediones, insulin. We have newer antidiabetics like DPP-4, GLP-1 agonists, and SGLT2 inhibitors. Let's take out the ones which do not have a additional effect on NASH. So we are left with metformin, thiazolidinediones, GLP-1 agonists, and SGLT2 inhibitors, and we are going to focus around them. A brief talk will be about sulfonylurea, which our eminent panelists will elucidate, where to use them, how to use them. That's something which we need to understand because most of the patients are already on sulfonylureas. So let's go to case number 1. 50-year-old male patient, 2 times raised ALT, diabetic, known for almost 10 years, on glimepiride 2 milligram, badly controlled sugars. Fasting blood sugar is 177, HbA1c is 7.9. He's obese, 33 is a BMI. There's no hypertension, no dyslipidemia. And you find fatty liver on ultrasound. All other etiologies are ruled out. Next step we do is we assess fibrosis. You may choose to do a NAFLD fibrosis score or a FIB-4 score. And of course, you have fibroscan or elastography, whichever you choose to do. And you can classify this patient into whether the patient has fibrosis or does not have fibrosis. So our index case has a NAFLD fibrosis score of 0.66, FIB-4 has 2.5, and fibroscan is 10. So we are dealing with a guy who's a diabetic, who has uncontrolled sugar, and who has some fibrosis but not cirrhosis. That's what is apparent from the initial investigation which we have. Now we have an audience poll here. I would urge all audience to vote. We have 3 questions for the audience. And from the audience poll, we subsequently move on to the panel's opinion. So what would you do? I've told you the profile of the patient. Uncontrolled sugar, would you increase the dose of glimepiride? Would you stop glimepiride and change to another antidiabetic medication? Would you continue glimepiride and add one more antidiabetic medication, or would you start insulin? Audience, please. Okay, so most of us think that we should change glimepiride and to another antidiabetic medication. Let me start with Akash. Akash, what would you do? So what would you do of these 4? What would be your opinion? So this guy, you don't have your mic working, right? Can we have a mic for the panel? Got it.
So I think you have to understand the context. I think this is a patient who is diabetic, is obese, and who has at least significant to advanced fibrosis, perhaps what we will today put as compensated advanced chronic liver disease. The glycemic control is not that good with glimepiride. So as of at this stage, directing at all the 3 parameters, I would have to decide as to what those particular context I'm addressing, whether I'm addressing the obesity, whether I'm addressing the fibrosis, or whether I'm addressing the diabetes. If we are specifically looking at the diabetic part with respect to the current question that was posed, I would possibly go on to add in another drug in addition to glimepiride. But that would not be possibly, again, that choice would be directed as to how those would be good, both at my obesity control and my fibrosis control.
So most of us, the panel agrees on that we would add one more antidiabetic medication. So this guy is already uncontrolled on a 2 milligram of glimepiride. So you want to add on one more medication. So if we have to choose a medication, would you like metformin to be used here, or what are your comments?
So again, that would bring on to the context of usage. If it is only for the glycemic control part, metformin is a modest drug with certain degree of glycemic control. But if again I have to look for the other parts of it, that is the liver-directed component, metformin, I think data from all the meta-analysis has now shown that it's not good either at NASH resolution or at prevention of fibrosis. So for that part of it, for the control of the diabetes, possibly metformin can be added on. But again, the other 2 components of obesity and the liver fibrosis may not be well addressed with metformin.
Okay, so metformin is a decent option, but metformin by itself is not a very strong anti-diabetic drug. You may not be able to control your sugars significantly with this, but it's a good drug to use. It causes weight loss. It leads to decrease in liver enzymes, although there is no data on improvement in fibrosis. Samir, what do you think about SGLT2 inhibitors?
See, what we have already discussed, that sugar control is very important. Glycosylate hemoglobin is 7.9%. And patient has got non-morbid obesity with raised enzymes. So SGLT2 inhibitors are a very promising drugs because their oral formulation is available. They are relatively cheap as compared to other drugs like GLP analogs, and they lead to better sugar control, weight loss. And side effect profile in non-cirrhotics is reasonably good. So I think SGLT2 is a very promising drug, but I would agree that first we add metformin, see how the sugar gets controlled, how the weight gets controlled, and then we look at a stronger group of drug, that is SGLT2 inhibitor in a non-cirrhotic.
In a non-cirrhotics, of course. Dr. Gupta, so you would also add metformin first or straight away jump to SGLT2? You have a different opinion, or you would agree to that?
Add metformin first.
Okay, so most of the panel agrees that we add metformin first. Just to give you some data on SGLT2 inhibitors, there are few papers published from India, although none of this is a biopsy paper, but it has been shown to be improving fat in the liver. This was a RCT published from Medanta group, the endocrinology Medanta group. The fat fraction was assessed by MR-PDFF. They also looked at fat reduction, they looked at AST-ALT improvement and baseline weight, and all three showed improvement. So the fat was reduced, ALT was decreased in the group which got empagliflozin, and the baseline weight also improved. So it's a useful drug to use. We also have a meta-analysis of 10 randomized controlled trials where SGLT2 inhibitors have been used in NASH patients with diabetes. And again, no biopsy data, but there is improvement in FIB-4 scores, there's decrease in fat in liver, and improvement in AST-ALT also. What we need to be sure, what we need to be very careful is that by themselves, SGLT2 inhibitors do not have a significant hypoglycemic effect. But when you are adding them onto a sulfonylurea, we'll come to you, sir. So when you are adding them onto a sulfonylurea, they may cause hypoglycemia or exacerbate the hypoglycemia, so you have to be careful in adjusting doses. Dr. Dusja, you want to make a comment?
I don't know how many of you there last weekend when we discussed in the best of ACG some of the papers in the liver session. There was a paper in the liver session which I presented and moderated. I think the first author, I remember Ahmed or somebody. Large database of around, I think, how many million people, and 29,000 or somebody NASH with diabetes paper. That paper, and that's paper on diabetes with NASH, very large number, I can't remember the exact figures. There, they had shown that if you have diabetes and NASH, and if you use SGLT2 inhibitor or GLP-1 agonist, then they followed them up on a huge number, I think the years. The risk of having cirrhosis drastically goes down. So I think the choice, if it's not only the sugar control, if you have
Absolutely.
to talk about the hepatologist's point of view, probably we have to choose the GLP-1 or the SGLT2.
So that's absolutely correct. Dr. Sanyal, you want to make a comment?
One more thing. And another thing, Manav here. See, another thing, when we put these patients on these drugs, we need to assess them at around 3 to 4 months. Say they are relatively expensive drugs. What we need to do is, studies have shown that if you assess them at 3 months, and if they show response, then they hold promise for a long-term solution of the problem. That's
fair enough. And there is so much collateral advantage of using this drug. They are renal protective. They have been shown to be cardio protection by these medications. Dr. Sanyal, please.
Yeah, I just want to make a couple of points. Throughout the world now, I think sulfonylureas are a drug of the past. They have absolutely zero impact on the things that kill the patient, which is cardiovascular disease, chronic kidney disease, strokes, etc. And so, metformin is the first line therapy because it actually has an impact on all those outcomes. And then I think GLP and SGLT2s are the current standards. And over here particularly, there's a practical element of whether the patient can afford a GLP-1, but certainly an SGLT2 is orally available and would make a lot of sense. The main reason I got up actually is you have to be a little cautious about looking at changes in FIB-4, because anything that makes your liver enzymes come down will improve your FIB-4. That doesn't necessarily mean your fibrosis got better, because AST, ALT are not a direct function of fibrosis. It was designed originally to identify at one point in time how it correlates and gives you the risk of having advanced fibrosis, F3 or F4. So it's not a disease monitoring tool. So that's probably, I won't put too much money on changes in FIB-4.
Fair enough.
Again, coming to the metformin, again, there was another paper You know, there's a retrospective data on metformin usage in bridging fibrosis and cirrhosis by Nagachala-Sani's group, and also on vitamin E, where they had shown your requirement for transplant, your decompensation goes down.
Absolutely. So
the
whatever.
The prospective paper in the best of ACG what we moderated was paper of cirrhotics and on metformin plus GLP-1 agonist. Your risk of decompensation and everything goes down. It's good to combine metformin with maybe a GLP-1.
Great. So the new kid on the block is GLP-1 agonists. That's what Dr. Sanyal has been talking about. That's what Dr. Duseja has been telling us. The problem here is, so I will talk about GLP-1. The only problem is, one, availability, second, cost, third, injectable drug. It's a very good drug to use. We have good data to support that. Piyush, you want to comment upon your experience on GLP-1 agonists, and would you use them in such patients?
Well, the endocrinologists have been using them for a long, and I mean, the cost is a problem, and a few side effects are a problem. The tolerance is a problem. Otherwise, they're good drugs. They cause weight loss. They provide other cardiovascular benefits which are there, and they provide good glycemic control also. So actually, in an obese patient who has got cardiovascular risk factors, apart from SGLT2 inhibitors are easier to use. GLP-1 agonists are a little difficult to manage in day-to-day setting. Otherwise, these are just as good drugs as this thing. And as Dr. Sanyal was mentioning and Dr. Duseja was mentioning, combining them with metformin, because metformin also has got pleiotropic effects. Metformin in this patient should have been the first-line drug, in fact. Glimepiride in an obese patient is not a very good drug to go with in the beginning.
So GLP-1 agonists and SGLT2 inhibitors actually have a lot of collateral benefit. The improvement in metabolic syndrome profile, the improvement in other cardiovascular risk factor benefits which they have are huge. We know about this NEJM trial which has been published, which showed that it does need to NASH resolution, although improvement in fibrosis was not shown, maybe probably because of the shorter follow-up. Once you go have a longer follow-up, it might even show you improvement in fibrosis. The problem with GLP-1 agonist, one of my patients, he came back to me and told me, he was put on GLP-1 agonist by one of our endocrinologists. He says, sir, I have lost so much weight, but the problem is, along with losing weight, I have lost my desire to live also. I can't eat anything, I'm always full. So I feel like vomiting every time. So it's not a drug which is devoid of a few GI side effects. That's the most common problem here, but that's again in the lighter vein, it has a much more benefit than the problems. So GLP-1 agonists have been shown to improve NASH. They have been used in cirrhotics child status A, both semaglutide and liraglutide. Improvement in fibrosis is doubtful, but I guess that will also be proven in time to come. What did I do? I chose the easier option. I added empagliflozin. The patient did improve, and over a period of time, the enzymes settled down, the sugars came under control. To summarize, first case, metformin, all the panel agrees, is a good drug to use in NASH with diabetes. You see weight loss because of this. It may not improve fibrosis. The improvement in fibrosis data is only surrogate, not direct, but it is a weak anti-diabetic drug. You do not expect to control badly uncontrolled sugars with metformin. SGLT2 inhibitors are nowadays the preferred anti-diabetic medication in patients with NASH because of oral availability, cheaper drug, easier to use. Glutides improve ALT and possibly fibrosis in NASH patients. Problems are injectable drugs, more expensive, not easily available in India as of now, but both SGLT2 inhibitors and glutides significantly improve weight. Let's move to case number 2. Akash, you want to comment?
Just this one, sir. I think there is still some interest with low-dose pioglitazone, possibly 15 milligram in those who are not obese, not in this case possibly with 33 BMI. But then there's a guideline statement from American Society of Endocrinology practice directed towards endocrinologists, which actually puts in pioglitazone as a strong recommendation across the state of fibrosis, but possibly starting with a low dose of 15 milligram on people who are non-obese, and then adds in a GLP-1 or an SGLT2 is not there in their guidelines.
Absolutely, Akash. That's a very important point you made. And we all remember the original paper which Dr. Sanyal published. Pioglitazone has been shown to improve NASH in non-cirrhotic population. It's a good drug to use. I personally don't like it, but yes, it has benefits. Let's go to case number 2. 56-year-old male, 20 years diabetes, morbidly obese, BMI of 39. has dyslipidemia and hypertension, is on gliclazide, pioglitazone, statins, and antihypertensives. Ultrasound shows fatty liver. You can make out from the liver profile that he probably has cirrhosis. AST is 128, ALT is 90, albumin is 3.3. Sugars again are uncontrolled, fasting 175, HbA1c of 7.7. All non-invasive markers tell you that this patient has compensated NASH-related cirrhosis. Audience poll again. What would you do here? So this is compensated cirrhosis, NASH, uncontrolled sugars. Would you increase the dose of gliclazide? Would you increase the dose of pioglitazone? Would you change these drugs to either metformin or SGLT2 or GLP-1, or would you start insulin in this patient? Audience poll, please. Can we have the results, please? Okay, so most of us think right. We have to stop them and change to either one of these three medications. Dr. Sanjay, so would you use metformin in a child age cirrhotic, well compensated? If yes, what would be the things you would look for and advise?
Personally, I think that metformin is not so well tolerated when we see it in practice. People do have GI side effects, and we have to restrict the dose of metformin. In this case, the first thing that came to my mind actually was insulin. I would have felt safe to initially put him straight on insulin, bring him under control, and then switch to the SGLT2.
Okay, so initially insulin to control the sugars, yeah, and then shift on to
he is obese.
Okay.
His A1C is 7.7. He is cirrhotic. There may be some latent infection somewhere at his age. Typically in these patients in practice, we find that there is a asymptomatic bacteriuria, which may be a clinically evident urinary infection. I would, in practice, first feel safe by putting him on insulin and making sure that all other metabolic parameters are in control, and then switching him to oral drugs.
Okay, so metformin, restrict the top dose, don't go beyond 1.5 grams. I've already said that it's a weak anti-diabetic drug. You cannot trust this drug to control the sugars too much. It may be an add-on to another medication, but by itself it may not be so good. If you have renal impairment, don't use it. Child B, C, absolutely contraindicated. Anybody who is abusing alcohol, don't use metformin. Dr. Sameer, what would you do with the gliclazide which this patient is taking, and would you like to comment on the use of sulfonylureas in these patients?
So the problem is patient has got compensated cirrhosis. Now the issue is the half-life. We need to choose a drug which has got a relatively shorter half-life, because metabolism is compromised. So even if we have to do it, we use a drug like glipizide which has got a half short life, and we need to monitor especially nocturnal hypoglycemia. That is one which can happen. So if we have to increase the dose, we have to make sure that we monitor these patients properly.
So gliclazide, we generally, it's outdated drug. It's got a half-life of 12 hours. In a patient who has cirrhosis, the half-life would go up to 18 to 24 hours. You have higher incidence of hypoglycemia. And same goes for all sulfonylureas, actually. They are metabolized in the liver. So even your glimepiride, which is the standard sulfonylurea to be used, it has got a half-life of 8 hours. In cirrhotic, it goes up to 12 hours, 14 hours. So if you have to use a sulfonylurea, I'm not saying you should use it. As Dr. Sanyal said, sulfonylureas are mostly drugs of the past, especially in context of liver disease. They should be avoided in cirrhosis. If you have to use it to control sugar, use a shorter-acting one. And the shortest-acting ones are either repaglinide or a glipizide, which have a half-life of 5 hours in a non-cirrhotic patient. And of course, in a B and C status patient, you should not be using these drugs. Dr. Piyush, any comments on pioglitazone? Would you want to continue pioglitazone in this patient, or would you like to change it?
He's an obese patient. His BMI was 33, if I'm...
39.
39.
Yep.
So pioglitazone has to be stopped. Beyond a BMI of 30, pioglitazone should not be used. Water retention, weight gain, these are the known side effects. And apart from the other things, pioglitazone is a drug which has been shown to have reduction in fibrosis, steatosis, but obese patients, pioglitazone has
So over and above obese, even in cirrhotics, we don't have any data.
Yeah.
So, and moreover, it is a drug which can cause hepatic impairment. It should be avoided in patients of cirrhosis. That's what we would practice. Pioglitazone in cirrhosis is a no-no for us. If the bilirubin is more than 1.5, its enzymes are more than 3 times raised, it should not be used. If you want to use it for whatever reason in a compensated child A5 cirrhotic, use lower dosages, as Akash talked about. Start with 7.5 or 15 milligram, and you have to monitor LFTs frequently. I would probably not use a pioglitazone in a cirrhotic patient. Dr. Gupta, what is your comment on SGLT2 inhibitors in this scenario? We have already heard that GLP-1s and SGLT2s are good patient drugs to use in NASH patients. In cirrhotics,
thing is that they are available right now in India. They are not very expensive also, and the mechanism of action is wonderful. That is, they prevent reabsorption of glucose from the proximal convoluted tube, meaning thereby that causing glycosuria as well as weight loss. So all in all, particularly as Dr. Ajay was mentioning in the last ACG meeting, best of ACG paper, he mentioned that NASH, you can safely go ahead with SGLT2 inhibitor. Plus, you may add metformin if the dosage is to be higher. So means in cirrhosis, particularly child A, metformin may be the choice. But in NASH per se, SGLT2 inhibitors are a better choice.
Dr. Sanjay, you want to comment on that? Would you use in a child A cirrhotic? You would. You will not use it.
No.
You will not use it. Any particular reason you want to avoid it in child A?
NASH without cirrhosis.
Akash?
I think there's still we don't
and even
have
child A cirrhosis.
Child A. Akash?
We still don't have data to say that we'll use or not use. But again, we have to think what are the outcomes we are looking at, whether we are looking at liver outcomes or we are looking at cardiovascular.
We are looking at the patient, Akash. We are looking at the patient to live longer.
If somebody has with expected cardiovascular outcomes, I would possibly not be denying as good a drug as SGLT.
Absolutely. So that's very important to understand. This is a guy who has dyslipidemia, who has hypertension, who has diabetes, which is uncontrolled. He's child A cirrhosis. We know that it does not have hepatotoxicity. What we have to be careful about is, so how do SGLT2s act? In addition to other metabolic changes, they also cause glycosuria. They would put out glucose in the urine, and patient also has higher urine output because of that. Now, if the patient is on diuretics for whatever reason, now this patient is not on diuretics, he's a compensated cirrhosis. If your patient is on diuretics, then you have to be very careful. They can lead to dehydration, they can lead to hypotension. Older women have smaller urethra. You have higher incidence of UTIs in them. So this is something which you have to remember when you're using these drugs in this.
In fact, we used in a couple of patients, and particularly in females, there is, one must rule out a urinary tract infection. That is very important.
Absolutely. So SGLT2 inhibitors are safe in CTP child A patients. We have data on that. They should be used with caution in B or maybe avoided. CTPC, we have no data. We should not be using at all. If the patient has renal impairment or on diuretics, we should not use them. GLP-1 agonists. A lot of data is coming in. I guess 2 days back, a paper has been published in Lancet by Lumba, Dr. Lumba et al., which says that it is safe in cirrhotics. That's where it stops. It has not led to improvement in fibrosis. It has not led to improvement in NASH resolution, but AST-ALT improved, fat fractions improved, and it did not have any unanticipated side effects. So GLP-1 agonists are reasonably good drugs to use in a child A cirrhotic. We cannot have any recommendation of child B or child C patient. So what I did in this patient, I would stop both gliclazide and pioglitazone, as we have already discussed, why higher long life, longer half-life, and sulfonylurea we want to avoid. Pioglitazone anyway should not be used in cirrhotics. We started the patient on glipizide and dapagliflozin. The patient improved. Sugar started improving, but then he lost to follow-up. As usually happens, the moment the patients improve, they would not come back to you. And they'll come back a year later. And now, the sugars are still well controlled. In fact, his HbA1c dropped to 5.1, more than well controlled on the combination of these two medications. Developed ascites, bilirubin went up to 3.2, and the INR also increased to 1.5. Now, this was a child status A5 patient. Now he's B9. What would the audience do? The sugars are well controlled. The patient has decompensated. Would you continue same dose of glipizide and dapagliflozin? Would you decrease the dosages of these medications? Would you stop them, change to liraglutide? Would you stop them, change to insulin? Let's see what the audience thinks. So that's the advantage of having a gastroenterology audience which understands everything. Piyush, what is your choice of drug here?
So absolutely, now this patient has decompensated, ascites, bilirubin going more than 3. So there is, the data on uses of all the drugs, the safety, the metabolism. Insulin is the safest drug to use in this scenario. And again, here also you have to use a decreased dose of insulin. Insulin is predominantly metabolized in liver. So insulin also has to be used with caution. The newer insulins have to be used because insulins are metabolized predominantly by hepatocytes.
Absolutely. The other important thing which we have to remember is if we use
one small point, HbA1c in cirrhotics is not a very good marker of glycemic control. You have to look at fructosamine probably if you are looking at glycemic control.
Or maybe 3 times a day sugar, whichever way it suits. But HbA1c is not a good marker for somebody who has decompensated cirrhosis. That's a very important point. Secondly, if you have to use a long-acting insulin, the standard practice of using at 10 p.m. should be given away in cirrhotic patients. Please use a 10 a.m. insulin. You don't want night hypoglycemias in these patients. Any other drug except insulin has not been proven to be safe. We have highlighted that in the previous discussion in the cirrhotic compensated patient. To summarize, when we are treating cirrhosis with diabetes and NAFLD, avoid sulfonylureas, avoid pioglitazone. Metformin, glutides and gliflozins can be used in CTP-A cirrhosis. But once you have a late B or a C, the only safe medication is insulin. I think I will end here and invite any comments from the panel. We still have 1 minute to go. Dr. Chawla, please.
I think one very important message which everybody needs to carry is metformin is safe. And as Dr. Ajay mentioned, in the last week, we had that wonderful presentation of GLP-1 and metformin preventing decompensation and HCC. Metformin prevents HCC development also. So I think that's an important carry-home message. And SGLT2, just by the way I was going through, it is a drug which could be used in refractory ascites also. And it has shown some relatively good results, but a very small study. Because again, you said glycosuria happens, so it improves the diuresis, just as a spin-off.
Dr. Bhatnagar, you want to comment, sir?
I think they were very informative cases. I think my takeaway from this is to re-educate myself on the anti-diabetic drugs. I think we, as gastroenterologists, that's not a statement on you, Manav, but I guess most of us need to beef up on our reading about these newer drugs.
See, Dr. Walsan started with the concept that there's a chicken and egg story between diabetes and liver. I am of that school of thought that which says that liver and diabetes, they are so much interlinked that liver dysfunction affects diabetes and vice versa also. So we need to update ourselves. Absolutely, we need to start handling these drugs more confidently. Dr. Sanyal, you have a comment to make, sir.
Yeah. I think the world of diabetes is changing very rapidly also, and we take a little bit different approach even for our decompensated cirrhotics. We really try to minimize exposure to insulin because insulin makes, besides the risk of hypoglycemia, it makes you gain more weight. And particularly for patients who are waiting for transplant, that can create a whole additional set of issues. And so we have reasonably good experience with GLP-1s and SGLT2s in this setting.
In a decompensated
It's also important, it's mostly clinical experience. It's not a controlled study.
Right, sir.
This is in our pre-transplant people who are diabetic. And because now, NASH is the leading thing that we see in our pre-transplant clinic. So the other thing to remember is GLP-1 really improves your atherogenic cardiovascular risk. Doesn't have much of an effect on HFpEF. On the other hand, and there's a differential effect between strokes versus actually coronary events. And much of the MACE benefit was through strokes rather than coronary events. And SGLT2s actually also don't affect coronary events so much and do affect the myocardium. The last thing that you guys didn't talk about is probably because of time, is what do you do with their statin as the patient decompensates? Because once a patient decompensates, you know, the statin exposure level really changes quite dramatically. So that's something else to be aware of.
Just quick, I think since the session was on diabetes and NASH, you know, maybe Professor Sanyal can make a comment on that. The recent ASLD 2023 guidelines, when it talks about, you know, prescribing various drugs, it says vitamin E can be considered, pioglitazone can be considered in non-cirrhotic. It also says that GLP-1 agonists can be considered in patients with NASH if they have obesity or diabetes, which means the vitamin E, pio, and GLP-1 coming as one of the recommendations in ASLD.
So that's what we said, sir. So that's very clear. The only question is that once we have decompensated, now Dr. Sanyal tells us that even in decompensated we can use GLP-1. That's news to me. So maybe we'll try that in our clinic and see that.
Dr. Manav, we have to wind up.
We are short of time.
Yeah, remember that GLP-1s do not have any receptors in
Absolutely.
the liver.
Yep.
So you dodge that.
Thank you. Thank you for your patient listening. I hope you learned something from this.
Yeah, I request the moderator to hand over a memento to our speaker, Dr. Manav.
A big round of applause to Manav. He made it clinically very relevant, and that should have an impact on all of our day-to-day practice. Thanks, Manav. And thanks to all the chairpersons and moderators. Dr. Chawla, little closer to others. Thank you. Before the next announcement, which Ashish will make, I must tell you there was a little faux pas on my side. During the introduction, it was just an oversight that I forgot to mention that this whole program is being brought to you as a joint venture between INSL and Hope Initiative. Needless to say, the logo of INSL was there, but with Ajay Duseja there, I thought that, you know, he might catch me by the collar in the end of the day. So it's a correction from my side. My apologies. Hope it's okay with you, Ajay.
Thank you, Dr. Chaudhary. So as we all know, in patients of NAFLD, the most common cause of mortality is actually cardiovascular diseases. So our next session is on cardiovascular diseases and NAFLD. And for this, I would like to invite our chairpersons, Dr. Nutan Desai, Dr. Manas Panigrahi, Dr. D. Srinivas, and Dr. Nitin Borse. And I would also like to invite our moderators for this session, Dr. T.N. Lahiri Mazumdar and Dr. Pavan Rawal. I would request the chairpersons to call upon the moderators and also to introduce the speaker, who is none other than Dr. Arun Sanyal. Chairperson, please.
Thank you, sir. So I would like to request Dr. T.N. Lahiri Mazumdar, sir, and Dr. Pavan Rawal, sir, to come up in the dais. And I don't think Professor Sanyal needs any introduction. So Dr. Sanyal, sir, please come up the dais.
Yeah, thank you, Gaur, for putting on a photograph from 25 years ago. It reminds me what I looked like then. So we're going to continue this conversation about the non-hepatic connections to fatty liver disease. Once again, here are my disclosures. And I always start with the same place. That is talking about, you know, fatty liver disease in a more holistic way. But as you can see over here, that the person with fatty liver disease, their beta cells are under stress, their myocardium is under stress, their arteries are under stress, their kidneys are under stress, and there's tremendous crosstalk between all of these organs, and each of these organs affects the outcome of the other one. So there have been a lot of different studies that have actually tried to look at cardiovascular outcomes in populations with fatty liver disease and report an increase in cardiovascular outcomes.
but there is a background of cardiovascular risk in these patients from their underlying obesity, insulin resistance, dyslipidemia, systemic inflammation, etc. So it is very hard to tease out how much of the cardiovascular risk comes from the liver, whether the liver truly actually contributes to the cardiovascular risk, or whether this is really all a function of the metabolic milieu in which the fatty liver disease develops. And this was really addressed in this particular study called the PROMISE study out of Harvard, where they looked at 10,000 patients, and of these, about 3,756 had liver imaging, and they found steatosis in 25%. And over here, after addressing all of the other confounding factors in a background, coronary stenosis, risk scores, obesity, and all the features, they found that indeed those who had fat in the liver had excess cardiovascular. There seems to be now, I think, well established that having fat in the liver is a risk factor for having coronary artery disease. So this is an area that we've been interested in for a very long time. And Shadab Siddiqui, when he was a fellow, he's one of the authors of the practice guideline from ASLD now. We showed that as you go first, this is a population study of people coming in Virginia for a routine annual checkup. So it's, I think, 6,000 or 7,000 patients. And we looked at those who had low normal ALT, high normal ALT, or elevated ALT at the time of their routine annual physical examination. And you find that those who have increased liver fat based on ALT as a surrogate, they had increased small dense LDL cholesterol, which is the LDL cholesterol particle that is most atherogenic. And then we moved on to looking at this led us to ask the question, well, we really don't have histology. ALT is a poor biomarker for fatty liver disease. So then we looked at lean, obese, without fatty liver disease, and yes, they do exist. And they are not very insulin resistant, and you have to really work hard to find them. And then you go to fatty liver, and then to actual steatohepatitis. And you see a progressive step up, particularly with fatty liver, and even beyond fatty liver, those who have steatohepatitis, they have increased small, dense LDL. And it's really the small, dense LDL that really contributes to atherogenic risk. And if you look at the particle size of the LDL, both in non-obese and in obese individuals, compared to those without fatty liver disease, those who have fatty liver disease tend to have smaller LDL particle size. So the smaller the LDL particle, the more easily it penetrates the arterial endothelium and goes into the macrophages and produces an inflammatory atherosclerotic plaque. There's also now data that there is greater worsening of coronary calcium scores in those who have fatty liver disease. So not only do they have higher coronary calcium scores at baseline, but it tends to increase at a more rapid trajectory compared to those who do not have fatty liver disease. When you look at coronary dysfunction, what we mean is that we have an artery, when you're exercising and your muscle myocardium is working harder, asking for more oxygen, your coronary arteries dilate to compensate and provide the myocardium the flow and oxygen that it needs. This is impaired. Even without fixed stenosis, the degree of coronary reserve in patients with fatty liver disease is impaired. And this has been shown now in a number of studies, and this is one that is we show over here. And what really then is the question? So how does the fat in the liver connect to what's going on in the heart? So this is really a function of two things, ectopic fat and metabolic inflexibility, which connects the liver to the heart. So there are many different potential mechanisms by which fatty liver disease can link to the cardiovascular system. And these are all summarized over here, that first of all, the liver itself is producing, is a principal source of cholesterol synthesis and triglyceride. And if you look at the lipoproteins that are the principal drivers of atherogenic risk, They're all coming from triglycerides and LDL cholesterol. So it is principally coming from the liver. When you have NASH, you're also releasing inflammatory cytokines, and you're releasing inflammatory extracellular vesicles. You can create a hypercoagulable state. So it's a combination. Inflammation has become a very important concept. It's not just the cholesterol or the triglyceride, but it's vascular inflammation. So in NASH, we're concerned about injury and inflammation as a driver of fibrosis. In the arteries, it's injury and inflammation from the atherosclerosis. Atherosclerosis is nothing but NASH of the arteries, and so on and so forth. So all of these, there's a biology connecting these. And then very interestingly, at least for some of the genetic variants like TM6SF2 and PNPLA3, it turns out that if you retain the fat in the liver, particularly for TM6SF2, then you get less cardiovascular disease. You get more liver disease and less cardiovascular disease. So one of the big unmet needs in the field really is to be able to look at a patient and say, you have this amount of cardiac risk, you have this amount of liver risk, this amount of kidney risk. And as you treat the patient, as one of the risks comes down, relatively, what is the contribution of other things to the mortality risk? And I think this is a very important question that we have to answer in the future. So how does this whole cholesterol business, this is the part that is best worked out, and this is from our work from now over 10 years ago. So what happens is there is a dysregulation. Normally, if your cholesterol level in the liver goes up, the liver is pretty smart. It shuts off cholesterol synthesis. And what we find is there is a dysregulation of cholesterol sensing within the hepatocyte so that the HMG-CoA reductase is actually turned on despite tremendous amount of free cholesterol accumulation in the liver. And so that leads to more of this cholesterol coming out in first VLDL, and then that gets transformed into LDL. Now, LDL is cleared also by the liver through LDL receptors. And normally, HMG-CoA and the LDL receptors move in what we call coordinately. What that means is they both go up or they both go down. They always move in the same direction. But in NASH, they go in opposite directions. And what we find is that these patients actually have a lower level of LDL receptors. So that further, so not only are you putting out more cholesterol, but you can't clear it from the blood, so more contact time with the arteries. So that's part of that cholesterol story. Now, we've now also looked at the other part of the story is the muscle. Striated muscle is the component. We know about adipose tissue, we've talked about it, we talked about liver, we've talked about heart, but striated muscle can take over many of the functions that the liver is supposed to do, and particularly oxidize fat and help us with glycemic control. Because when you eat and you get a sugar load, the principal place where you clear your glucose is in the striated muscle. And when you become insulin resistant, that is the first place where your sugar ability to clear a glucose load is impaired. The excess glucose is taken up by the liver and turned into fat. So we look at muscle volume and muscle fat. And these are data, these have now been fully published from the UK Biobank. And what we find is that even in those with fatty liver disease, the more muscle fat you have, the greater is your mortality and greater cardiovascular outcome. So that it's not just a direct link from the liver to the heart, but there are also additional, all these organs are talking to each other, and the role of the striated muscle and sarcopenia in our obese patients is becoming a very important topic. A lot of future work going on to try to figure out how we improve the sarcopenia. Can we compensate for what the liver is not doing by making the muscles work better, like we see in the Japanese sumo wrestlers, who have tremendously obese, but they are not metabolically that unhealthy because their muscles are also big. They not only have a lot of fat, but they also have big muscles that are actually, because they exercise a lot, their muscles actually are very efficient at oxidizing a lot of the metabolic substrate and reduce the toxicity to the arteries and to the liver. The next thing to talk about is diastolic dysfunction. So we talked about the arteries, now we need to talk about the muscle. And the big thing, so there are two types of myocardial dysfunction. You have myocardial dysfunction with reduced ejection fraction and myocardial dysfunction with preserved ejection fraction. And this is, I think, a very important paper from a couple of years ago showing that those who have fatty liver disease, clearly they have more heart failure, they have more HFpEF, but the HFrEF actually is this in the middle. The reduced ejection fraction is the same. And we've seen over here that the left ventricular morphology and function are both impaired in fatty liver disease. You start seeing, even without hypertension, remodeling of the myocardium. The myocardium becomes thicker. It takes longer to relax in diastole, and so it does not fill properly. So even though it is contracting fine, it didn't fill enough. So you can't put it out, so you start developing progressive diastolic dysfunction. So from fatty liver disease, there are multiple points that connect us to diastolic dysfunction. First, there's obviously hypertension that can lead to myocardial remodeling and makes the myocardium more stiff. We've talked about lipotoxicity, that the liver's putting out all these toxic lipids, particularly ceramides that can affect the myocardium. And then there are changes in cardiac structure and function independent of metabolism. There's a component that could be through microparticles and other RNAs, etc. And then, of course, common elements to cardiac steatosis. So just like you get fat in the liver, if you do a T1 map of the, you can actually map triglycerides in the myocardium, and it's increased. And similarly, there's a signal for increased fibrogenesis in the heart as well. So there is a collinearity of disease progression between the liver and the heart. And you can see over here that patients who have more severe liver disease with higher Fib force, they also have more heart disease. And there is functional impairment and diastolic dysfunction in NAFLD. So this is a study where we took people who had no cardiac history but had fatty liver disease, and we exercised them, and we actually did stress testing while they were on the machine. And what we find over here is that the peak VO2 is lower as you go to higher stages of fibrosis, and their E to E prime, which is a measure of diastolic dysfunction, it starts decreasing as you get, compared to stage 0, people with stage 2 and 3 are lower. So the clinical implications of this and the future directions. So first of all, when a patient comes to see us, this being an important cause of mortality in our patients, we actually do all of the following. We do the ASCVD, we run the audit, we do a BNP, EKG, echocardiogram, and increasingly we're also doing coronary calciums for some of these patients, particularly those who have a bad risk profile. And then, of course, we focus on management, which is holistic. And you know, many patients are not the strict non-alcoholics, they drink a little bit more. But even there, I think we could counsel them about alcohol, and then we treat them with statins and fibrates. Statins, you should not be afraid to use them in patients with fatty liver disease. Very good data that statins are safe in this population. But remember, there's a lot of high residual risk, even after effective statin therapy. And that's where drugs like saroglitazar may be valuable, particularly if you have a very high cardiovascular risk profile, because it is approved for diabetic dyslipidemia, and it's very effective in reducing triglyceride and non-HDLC. And so saroglitazar actually has, and this is the data for triglycerides. So finishing up then, a look to the future, identification of subpopulations with specific type of outcomes, integrated approaches of assessing risk, predictive biomarkers, and then reduction of care fragmentation. Because now the patient is bouncing around between the diabetologist, cardiologist, hepatologist, nephrologist. The future is integration of these different cares and different types of care models for their care. Thank you.
Thank you, Dr. Sanyal. That was an excellent lecture. And one statement of yours did catch my attention, that atherosclerosis is the NASH of the arteries. That's very interesting. So before I open up this for discussion, my question to you is, in how many patients of NASH do you actually screen for cardiac disease using CT angio or something like that?
CT angio, we rarely do it. Unless the
CT
person...
coronaries, yeah.
Yeah, so this is our initial, what I showed on the, that's our initial screen. And then if it looks really bad, or if the patient has, strong family history, we'll do the CT angio. So it's a smaller, I would say about 10-15% of the total population is also getting CT and MR evaluation of the heart. So what we have done is actually we've incorporated somebody from preventive cardiology into our NASH clinic program, so that we have a diabetologist and a preventive cardiologist who's in the liver clinic.
So, sir, here.
Yeah.
So, in India, that concept of in a liver clinic, hepatologist, cardiologist, and all that concept have not come yet. So till then, we know around 1 in 3 are NAFLD, fatty liver. In our liver clinic, every other patient have fatty liver. So to whom I should send it to cardiologist? That is the basic question. At what point of time, or to whom I should send?
So it's a simple question, but the answer is quite complicated. Because first of all, I don't practice in India anymore, so I don't know what the situation is. You have to look in your own environment. I would suspect every person in this room has a very unique environment in which they work. So you have to know who you can trust and who you can send the patient to. My experience generally has been that the cardiologist only wants to put a stent in. If there is no procedure, they're like a luminal gastroenterologist. If they don't see a procedure, they're not interested in seeing the patient. And so you may be better off seeing a lipidologist or a diabetologist. And actually, because I did so much research in lipids in my early years, I actually am the go-to person for all lipid-related issues. So we manage all the lipid in-house, in my clinic. But I think you have to find out in your environment who is the person who's interested, who's knowledgeable, and who you can trust. That's probably more important than what specialty, whether it's a diabetologist or a cardiologist.
So as a rough guideline, we know that as the degree of NASH increases, the CVD risk also increases. Should we be screening all patients with F2 or above fibrosis and age more than 50?
So, we start long before age 50 because we see people having myocardial infarctions at the age of 35. So, and as you saw in my earlier talk, that the cardiovascular risk is relatively flat across the fibrosis stages. Part of it is because of our management, but that it shows you that even early on, there's significant cardiovascular risk. So I think right from day one, if somebody has fatty liver disease, somebody has NAFLD, that's a risk factor. And I showed you it's an independent risk factor after you add all the other things in. So I would say every patient with fatty liver disease should at least get a lipid profile.
So any role of, because this ectopic fat is supposed to be pretty bad, is there any role of screening for epicardial fat, pancreatic fat? And
not yet. There's no data to show that it adds value over and above an LDL cholesterol. The beauty of the LDL cholesterol is there's so much data and it's actionable. What you want to do is tests that lead to something actionable. And so the LDL is a good starting point. If you only want to do two things, probably an LDL and a coronary calcium score are the two things, because the calcium score has really emerged as a very strong risk factor. So that might be a population where you go for what they call intensive statin therapy, where you really are trying to push their cholesterol down to 70, the LDL down to 70 or less, as opposed to, just take some statins, get your cholesterol down a little bit kind of approach.
I have a question to you.
Yeah.
One of the slides we have demonstrated that procoagulants, cytokine injury, these things leads to endothelial damage. And subsequently you showed that diastolic dysfunction, leaving aside this calcium complex. Do you think this is how a person develops a cirrhotic cardiomyopathy?
Cirrhotic cardiomyopathy is probably a bile.
Different thing.
Yes, the cirrhotic cardiomyopathy is bile acids play a big role in that. So there's a lot of emerging data from Saul Karpin and Sam Lee's lab on the role of, when your bile acid levels go up, they produce diastolic dysfunction and cirrhotic cardiomyopathy is a function both of the hyperdynamic circulation, which is from the peripheral vasodilation, which is a nitric oxide mediated phenomenon. And then on top of that, there is bile acid toxicity that kicks in. So probably less of the microthrombogenicity in the cirrhotic cardiomyopathy than in NASH-related remodeling of the myocardium. There is a whole idea that, in the liver, when you have microthrombi, that is the driver of the fibrogenic response and nodular regeneration, and that it is possible that even in the myocardium, you might have microthrombi that might lead to a diastolic dysfunction from fibrogenesis. But the very recent data published in Circulation, I think just last month from Hopkins, they sort of discounted that hypothesis a little bit.
Then give us a guideline that for a gastroenterologist, how to look into the cardiac problems.
Sorry,
the multiple people talk.
For this session, I think we've reached the end point. We would thank the chairpersons as well as the moderators.
You've been cut off, Dr. Lahiri.
Okay. And could we please have
okay,
everyone
we'll have
on stage for a picture?
At dinner time, okay.
Okay, thank you.
Okay, thanks.
Could we please have everyone on stage for a photograph?
For exciting meetings, no amount of time is enough. We can go on discussing, but I think that's what dinner is all about. So we'll move on. But I'm so happy to see Dr. Tarun Lahiri Majumdar springing back to life and getting so active in asking questions now. Last few times I met him, he was so quiet. Thank you, sir. Okay, so we move on. The next topic will be announced by him. It has its genesis in a few talks which I heard from some of my junior colleagues. And I must say that one of them was Ashish. I very hesitatingly engaged him in a G-Talk session. And he's, by the way, an ex-student of mine, so I can be a little rough with him. But he gave a fantastic talk. It was meant for physicians. And that made me think that there are many aspects of obesity and NAFLD which we don't really dig deep into. We are looking at only the superficial part of it. So much of it comes from Ashish's talk. This time he'll be giving one of the 5 talks. But over to you to make the announcements. This, I think, should be one very important aspect in your day-to-day clinical practice if you can get information from me. Over to you. Please go ahead.
So we have covered diabetes, we have covered the cardiovascular risk, but we go ahead to obesity management and its challenges in non-alcoholic fatty liver disease. So for the session on NAFLD and obesity, I would like to call upon stage the chairpersons for the session, Dr. Verghese Thomas, Dr. Varun Mehta, Dr. Mandhir Kumar, Dr. Vandana Midha, and Dr. Sanjay Salunke. I would request the chairpersons to invite upon stage the moderators for the session.
We request the chairpersons, Dr. Harshad Devarbavi and Dr. Harshal Kadikar to kindly occupy the chair on the dais. They are the moderators.
Could we have Dr. Harshad, sir?
Harshad, Dr. Harshad and Dr. Harshal Kadikar are the moderators.
I think we have to call Dr. Parimal because Dr. Harshal Gadikar isn't here. Dr. Parimal will join us on the stage. Yeah.
We have 5 talks, one after other. The first talk is on obesity and NAFLD, the sinister association. And this will be done by Dr. Sunil Taneja, who's from the Department of Hepatology, PGI, Chandigarh. Dr. Taneja, please.
Thank you very much, sir. My sincere thanks to Dr. Godash Chaudhary and the organizing team for giving me this opportunity. And I'm going to talk about I'm going to talk about obesity and NAFLD, the sinister association. After smoking, NAFLD is the most common modifiable or preventable risk factor for all-cause mortality. And we also know that obesity and overweight is associated with a number of disease conditions. So there is a lot of data which shows that as the BMI tends to increase, there is an increase in the number of metabolic diseases. So I'll just start with this audience question. What are the components of metabolic syndrome? All except obesity, hypertension, diabetes, dyslipidemia, and NAFLD. So can we have the audience poll? So I think this debate on NAFLD and MAFLD, the change in nomenclature, is still going on, and I personally feel that NAFLD is the hepatic manifestation of metabolic syndrome. So let me just start with this very important paper recently published. This is published in Lancet, and a meta-analysis of 151 studies and more than 10 lakh patients, and look at the prevalence of overall NAFLD in overweight patients. It is up to the tune of 70%. NASH is up to the tune of 33%. And in patients who are obese, this prevalence goes up to 75%, and NASH is seen in around 33%. So the country-wise burden of the disease is also very high, varying somewhere from 30% in some countries to up to 90%. So the burden is huge, and obesity is one of the most important factors which leads to or contributes to this disease condition of NAFLD. Not only this, there is an increase in the significant fibrosis, and if you look at obesity, overweight and obese patients, in fatty liver, clinically significant fibrosis is seen in around 20%, and advanced fibrosis is seen in around 6%. And when you have NASH, it goes up to 35% and 20%. So significant fibrosis is also there in patients who are obese and have NAFLD. So what is the Indian data on this? This is the data from the ICON-D study, and obviously, there's high prevalence of obesity in NAFLD. Out of 4,000 patients, 16% were overweight, 73% were obese, and 84% had central obesity. Signals from the adipose tissue modulate a lot of metabolic functions, and this is through the paracrine effects, the autocrine effects, and the endocrine effects. And we predominantly deal with endocrine effects in NAFLD, regulation of appetite, insulin secretion, systemic insulin sensitivity, liver fat and fat deposition, and all these conditions further go on and lead to the development of fatty liver. So what is adiposopathy or obesity? It is defined as adipocyte or adipose tissue dysfunction caused by positive caloric balance and sedentary life in genetically and environmentally susceptible individual, and it contributes to a lot of metabolic disorders. So within the subset of obesity and overweight, you have either deranged endocrine or immune dysfunction, or you have abnormal and pathological forces. So both of these conditions finally contribute to the development of NAFLD. And just giving the concept of metabolic healthy versus metabolic unhealthy obesity, we heard Dr. Sanali was talking about sumo wrestlers, and they are those metabolic healthy obese, and metabolic unhealthy obesity is when you have insulin resistance, hypertension, dyslipidemia, sedentary lifestyle, poor nutritional status, and all these factors again contribute to the development of non-alcoholic fatty liver disease. So let's just look at the pathogenesis of non-alcoholic fatty liver disease. There is a metabolic inter-organ crosstalk in NAFLD and NASH, and central to this is the adipose tissue. The major source of non-esterified fatty acids in the liver is the adipose tissue. The rest comes from the diet, and some part is contributed by the de novo lipogenesis, which leads to formation of triglycerides and what we see as fatty liver. When you have adipocyte dysfunction, there is a release of adipokines and chemokines and other inflammatory markers which lead to development of inflammation in the liver, which leads to development of NASH. So let's look at the other aspect. In obesity, there is an expansion of the adipose tissue, which leads to adipose site dysfunction. There is insulin resistance, which is increased lipolysis, decreased adiponectin, increased leptin, and the pool of free fatty acid increases, which leads to fatty liver. Along with that, in obese patients, you have increase in dietary fat and carbohydrates, which also contributes to the increase in the fat in the liver. And as I said earlier, when you have this inflammatory markers which are coming in, it leads to inflammation in the liver and development of NASH. This is also contributed by glucotoxicity and the carbohydrate excess, which the obese persons or obese patients tend to consume. So what is the effect of obesity on non-alcoholic fatty liver disease? A very elegant paper published in Hepatology in 2017, 307 NAFLD patients, out of which 23% were non-obese. And look at the events, 28 versus 6%. So anybody who has a high BMI, they have high all-cause mortality, high cardiovascular events, high incidence of myocardial infarction. The liver-related events are also higher, and malignancies are also high. So there is also a published meta-analysis on the mortality and other impact of obesity in patients with NAFLD. This is a meta-analysis of 57 prospective studies. All-cause mortality, liver-related mortality, and mortality from hepatic malignancies all were increased in patients who were obese and had NAFLD. The data from the National Health and Nutrition Examination Survey also suggests that obesity is independently associated with liver-specific but not overall mortality in NAFLD patients after about 14 years of follow-up. So let me just conclude here. You need an algorithmic approach in management of NAFLD. You have to look at obesity also. I think we will have more discussion on the management of obesity and NAFLD over the next few sessions. But then lifestyle modification is very important. You have to lose weight. You might need anti-obesity medications and bariatric surgery. So target of weight loss has to be achieved if you need to improve NAFLD. So let me summarize here. Obesity plays a crucial role in the development of non-alcoholic fatty liver disease. There is a strong association of obesity with NAFLD and its severity based on pathophysiological and epidemiological data. Proper timely treatment is essential, and targeting obesity or fat redistribution may play a central role for the NAFLD management. Thank you very much for the patient listening.
Thank you, Dr. Taneja. The question is at the end, so please be seated.
Thank you.
In the audience.
We can invite the next speaker, Dr. Shalimar. He's an associate professor at AIMS, and he'll talk to us about genetics and obesity.
Thank you, sir, for the kind introduction. So my task is to talk to you about genetics of obesity and NAFLD. Professor Gaur Chaudhary said that this session would have multiple sessions. We'll cover topics in depth. Unfortunately, I'm not an expert in genetics, but I'll give you some concepts which I feel are important for us to understand. Our understanding of genetics have moved significantly over the past decade, and we moved from the candidate gene hypothesis. Now we've got techniques like GWAS, whole exome sequences, which has now given us a whole new approach to all diseases. So let's look at what's there in the genetics of obesity and NAFLD. A concept which is there, which I thought we all should know, is the thrifty gene hypothesis, which states that the maternal malnutrition which occurs during pregnancy modifies the programming of biochemical mechanisms related to endocrine metabolic control, inducing permanent changes in the glucose insulin metabolism. To put it in a nutshell, you got maternal malnutrition, there is selection of genes, which leads to more insulin-resistant phenotype, and the genotype, which leads to more insulin resistance. And we know, and we've heard on, what does insulin resistance leads to. An interesting concept, which can explain on some basis the occurrence of NAFLD and diabetes in our population. We began as hunters, where we used to get food, and food used to get stored in the body. Now we've moved from a state of hunters to a food adequacy. You got food available every day. So you don't need really is to store food or say the store fat in the body. Next, coming to the gene polymorphisms. You heard about this sequence in NAFLD: healthy liver, steatosis, development of inflammation, what we call as NASH, development of cirrhosis. Our understanding of these genes have led us to a lot of these being implicated. That includes what we've heard since the afternoon itself is the PNPLA, and there are some of the other genes which have been implicated. What I want you to know is each one of them have been shown to have some association in terms of progression, whether it moves from off the disease from a simple healthy liver to a state of fibrosis. Okay, let's look at, we heard the food goes, it's metabolized, and the liver plays an important role in accumulation of fats. So what are these genes really playing a role in the pathogenesis? Over here we know is that these genes, like the PNPLA, encodes for a lipase. So it is involved in the lipid droplet remodeling and leads to mobilization of fatty acids. So if there is an issue with this gene, you lead to more accumulation of fat. So that's where this PNPLA3 plays a role. You've got TM6SF2, which also again determines your intrahepatic retention of triglycerides. So modification of all genes is bad. So we know that some things which become bad gives you some good effects, some which become bad are also beneficial. So is this one gene which is known as the HSD17B13, which actually, if there is a mutation, helps you mitigate the effect of the PNPLA3. So these are some of the beneficial modifications of some of these genes which have been described in the literature. So put in a nutshell, again, some of those genes which get modified leads to development of NAFLD, where there are some other genes which help you in mitigating the effects. And what are these? These are these which is the HSD17B13, IL-28, and MERTK. So this table sums up the effect, and if you're interested, you can go back and read up very interesting reviews which are published. Due to shortage of time, I can't go in depth, but let's look at what's there described in the Indian population. We always talk about the Western population, what's there. So this review is, one is, yes, PNPLA has been described in Indian literature, has again an odds of 1.98 for development of NAFLD. There are other genes which have also been implicated in the Indian population. That includes the SERBP2 and the PPR gamma. Apart from that, there have been other genes which have been described from the other Asian populations. But what I want to highlight out here is the recent study from Professor Abhijit Chaudhary's group, in which they have implicated these SNPs for the development of non-alcoholic fatty liver disease. Coming to our important other aspect is the lean NAFLD, which we've heard since afternoon. Yes, there is our group of patients who have. Now, lean NAFLD, there are multiple factors. So could genes be playing some important role? I think this is one aspect which needs to be studied in more depth, especially in relation to our population, which has a little distinct phenotype compared to what has been described from the Western counterparts. UK Biobank data of 1,000 NAFLD patients. Lean NAFLD, which I want to highlight over here, now again has these two SNPs. One is the PNPLA3 and is another SNP which has been implicated for the development of NAFLD among lean populations. So this needs more study, especially in our population, whether this or other SNPs can be implicated, as we are going to talk about precision medicine in non-alcoholic fatty liver disease. Coming to obesity, we know that obesity has the terms which have been described as either the monogenic or the polygenic. Monogenic is something which has a strong genetic component, and we all know about the various syndromes which have been described. But the important is the common polygenic obesity is what we see and what we are talking about, which has a limited effect of the genes now which we know have been implicated, and our understanding and these other, I feel that there would be a lot more genes which will come up in future once more and more studies on different ethnic groups are available to us. Now coming to an important point, is there an interaction of obesity and non-alcoholic fatty liver disease? We know that obesity leads to non-alcoholic fatty liver disease. But you see this interesting study which has been published which shows that when there is this homozygous mutation in the PNPLA, see how when the BMI moves from less than 25 to 35, the effect is much higher when you got patients who got higher BMI. Same thing is that in a patient who's got a higher BMI, the presence of this homozygosity plays a major role in the development of non-alcoholic fatty liver disease. To sum it up, there is a susceptibility to NAFLD, and that is determined possibly by these genetic mutations, but we still need more data. So, ladies and gentlemen, to sum it up, my take-home messages are our knowledge and understanding of these genetics in obesity and non-alcoholic fatty liver is evolving, and it's still miles to go. Exact pathogenesis of both these diseases is still unclear. There are multiple factors which play, and genetics is probably one component, and we need to understand more about it. Does it play a role in lean NAFLD? I think this is a very important point for us, and we need to do more studies on it. And probably in future, what these genes can be implicated and what we can understand and what we can use in clinical practices for precision medicine, I think still we are very, very far from that point. And the most important other points are the issues is the availability of these genetic analysis. So even if you have, does it really implicate that the patient is going to get a disease? And what would be the severity? I think that understanding is still lacking, and we need more data. And do we really have those tools for interpretation of these tests is something which we need to see in future. Thank you.
The next speaker is Dr. Ashish. He'll be talking on eating behaviors and food choices, which has an important bearing on NAFLD and its different manifestations.
Thank you, Chairperson, and thank you, Dr. Chaudhary, for giving me an opportunity to present here. So, I would, my slides. Slides, yeah, thank you. So I would be talking about eating behaviors and food choices. So I would not be quoting much of studies. What I'll be talking about is most from the internet available, and it is all general knowledge. Most of you know about it. So I will begin with a question which we often ask our patients when we have advised them weight loss, and they come back after a few months with the same weight or even higher weight. So we ask, why did you not reduce weight? And most of the time the patient would answer that I have no time to exercise, I have pain in my knees so I can't walk, there are no parks around, I have started exercising but the weight is not coming down, I already do a lot of exercise, and I've got lots of stress in my family, I've got job tension, family problems, I have thyroid, I was on lots of antibiotics and steroids, so weight did not come down. So they would talk about everything, but they would no one would actually talk about diet. No one would say that I am eating so much and I have not been able to cut down on my diet. So what are the factors which make you obese? Dr. Shalimar just spoke about polygenic gene theory. And then your sedentary habits are responsible for making you obese. Your metabolism are responsible for making you obese. But the most important thing is your food. So how much you eat, what do you eat, when you eat are the most important factors which lead to obesity and which lead to difficulty in reducing our weight. So talking about eating behaviors. So why do we eat food? So we eat food mainly for 3 reasons. One is to survive. So this is called homeostatic eating response. So we eat because we have to survive, we have to carry out our daily activities, we have to give energy for our basic metabolic needs, basic metabolic requirement. But other reasons why we eat is, one is called hedonic eating. When we eat for the pleasure of food, we are not eating for survival, but we are eating because the food is so tasty. Food looks so tasty, it has got very good taste, texture, and the variety of the food. And the other, third reason why we eat is emotional eating. When we are depressed, when we are anxious, and then we start eating more, that is called emotional eating. So what is hedonic eating? When we eat for actually pleasure, it is driven by a desire for very highly palatable foods, which are highly processed. They have got high fat and sugar content or salt, and these actually food activate our brain's reward center, which I'll come to a bit later, which these reward centers release dopamine, and this dopamine is a pleasure hormone. And then repeated exposure to this highly palatable food actually make us addicted towards it. And then we keep on chasing these foods. And this leads to overconsumption and of these calorie-dense food and nutrient-poor foods. So when you are waiting for your flight and you see at the airport lounge, you see a lot of good food there in the food outlet, and then you grab the food even though you just had your lunch at your home, but you still eat it. Or when there's delicious food or pastry kept in your refrigerator, and even though you have had your lunch or dinner, but you open your refrigerator and eat. This is all hedonic eating. The second aspect is emotional eating. When we consume food because we are depressed, we are sad, we are anxious, or we are getting bored. And so again we tend to eat, and again we tend to eat the food which gives our self comfort. And that time also we tend to eat much larger food. And then there's emotional eating cycle. So something happens, something bad happens to you, you are depressed for some reason, you've had a breakup or something, and then you have an overwhelming desire to eat. And that urge to eat will make you eat more, and then you again start feeling guilty, and then this cycle goes on. So there have been many scientific studies on this emotional eating cycle. Then apart from the three types of eating I just mentioned, then there's one type of eating which is due to cultural norms. So we all eat due to festivals. We have Merry Christmas. Without cake, there's no Merry Christmas. Without gujiyas, there's no Holi or Diwali sweets. And then Eid. So we eat because of our cultural traditions, and these cultural norms also actually jeopardize our dieting or diet behavior. And then there's, after every grand weddings day, it is followed by grand parties. So we eat in these parties. And even while watching movies, it's been a common thing that we grab a huge tub of popcorn, and then it's become cultural, it's become a social obligation now. So there are two types of obesity. One is the metabolic obesity, which occurs because of our faulty metabolism, and which raises our set point body weight. But hedonic obesity is when we are eating because of pleasure, and then because of that pleasure we tend to gain weight. Coming to other food choices. So what foods do we choose to eat? So here's a trade secret. If you are planning to start a food chain, then start a food chain on junk food. For example, I'll give you here. The Burger King was started about 40 or 50 years ago, and at present they are located in at least 20,000 locations all over the world. At the same time, Whole Food Market was started. It was a healthy food chain, and it could not expand more than 500 locations in same duration of time. So, and this is one of the McDonald's ad, that free fries, you'll get free fries. So just add little more of money and you'll get double the amount of calories. So this is how these food chains or food restaurants, they target. So what they are targeting the reward center of our brain. So when we eat delicious meal, or when we get praise for anything, for many other reasons, there's an area called ventral tegmental area, which releases dopamine. This is the reward center. And that dopamine actually travels a little bit distance, and it reaches a place that's called nucleus accumbens, and it has got two functions. It gives us pleasure. So be it praise for something, be it anything like food or anything, or even alcohol. So we get pleasure from it. And the second thing which it gives us motivation to seek similar rewards in future. And this leads to addiction. So overactivation of this reward system leads to addiction. It can be addiction of drugs, alcohol. It can be addiction of compulsive behavior, even gambling, or eating disorder, and we tend to eat more. Then there's brain reward system gets hijacked, and then we have strong cravings for all this, and we have lack of control of this behavior. In 1954, the research was done on reward center on animals. Actually, they trapped a little mouse in this, and they fit an electrode to its brain. So whenever the mouse pressed this electrode, his brain got stimulated and he felt gratified. He had pleasure. So the rat continuously kept on pressing these levers, and it stopped only when it was fully exhausted. And when similar experiments were done on humans, they got similar results. So rats and humans are similar. So whenever we get reward, and even though the rewards have got no survival value, but we keep on seeking those rewards. So food, and now there's ample evidence that fat-rich diet or carbohydrate-rich diet actually also impacts our reward center of the brain. So all this we get lots of reward, the dopamine is released, and we tend to get addicted towards this food. And so we choose food which gives us more reward. So we would choose pizza rather than a healthy plate of salad. And even in our mobiles, we have obesogenic environment. So when we are browsing our mobiles, we see Swiggy, we see Zomato, and we see all the food which can give us rewards. So because of this, we tend to eat more, we tend to eat for these hedonic pleasures. Coming to the third aspect, that is satiety. As you know, once we have started, when we eat food, then a signal comes to us that now we have to stop. This is called as satiety. And there's a satiety cascade which begins even before when we have started eating food. So I have made this cartoon simplified. So the first part of satiety cascade begins with the meal quality, like how tasty the food is. So if the food looks very tasty, it will make us feel much more hungrier. The second satiety cascade, or the step of the satiety cascade, comes when it tells us when to stop eating. So when our stomach is full because of the stretch receptors, or certain hormones are released from the duodenum which ask us to stop eating. And the third is when to grab the next meal. So it depends on what kind of meal we have taken, and also on certain hormones like leptin or insulin, which decides when to take the next meal. And in people who are obese, all these mechanisms may be disturbed. And so satiety stimulus also depends on the type of food which we eat. So if we are eating food like donuts or pizza, we feel less satiated. And when we eat food which are like high in fiber content or protein content, we feel satiety much earlier. And there have been experiments where they compared people who ate food with high protein content compared to those who ate pasta. And after they had these food which was of equal calorie, they end up eating much more calories because they felt less satiated when they ate pasta or this kind of food. So take-home points, our eating habits, like the type of food, what we eat, how we eat, is the most important factor for obesity. And our brain's reward center gets overactivated with hedonic eating or emotional eating, and which leads to addiction and craving. And our obesogenic environment and our brain's reward center governs our food choices, what we eat, and this is a vicious cycle. And it is coupled with the dysfunctional of the satiety signal. So these are the problems which occur, and one possible solution can be mindful eating, and how we eat, how we choose to eat, and how we should take time in chewing food, and taking time in actually appreciating what we are eating is one of the possible solutions, which I'll leave it to you. Thank you for your patient hearing.
Thank you, Dr. Ashish, for this nice talk. Moving ahead, we move on to the next talk by Dr. V.K. Mishra. So another exciting talk by Dr. A.C. Anand, NEAT and exercise, including yoga for obesity. Dr. A.C. Anand.
Thank you, Dr. Chaudhary, for this opportunity. I've been asked to cover NEAT and exercise, including yoga for obesity and NAFLD. And this is the brief outline of my talk. I'll mainly be making 4 points. First, that exercise is effective in management of obesity and NAFLD. Second, the role of NEAT in obesity and NAFLD. Third, the role of yoga in management and obesity, management of obesity and NAFLD. And finally, how to motivate the patient for a behavioral change so that he exercises more. Now, obesity and NAFLD have become a nightmare for the health planners. Firstly, because they've become a public health emergency. Nearly half the world is either obese or having NAFLD. And second is, it is predicting an economic crisis in the world. And therefore, I'd like to begin with a key message from a very tiny friend of ours. This is a ruby-throated hummingbird who migrates from South America to North America every spring. And before her migration, she eats voraciously and gains almost 100% of weight what she has. And she becomes obese and develops non-alcoholic fatty liver disease. All this weight she loses in one single flight of 500 miles. The message she gives us is that both obesity and NAFLD can be cured if we exercise enough. Now, most people view obesity and NAFLD as the same disease. It's actually not the same. As far as the exercise is concerned, I'd like you to focus on the last line. Diet and NEAT are important in treatment of obesity, while exercise has a supportive role. On the other hand, for NAFLD, exercise benefits irrespective of weight loss, proportion to the time and intensity of exercise, and it is as important as diet and NEAT. So dieting is more important than exercise for obesity. I think my colleague Ashish has also said the same thing. Zipping your mouth is more important than exercising in obesity. For example, we are recommended 10,000 steps a day, and you can overcome the 10,000 steps with one just chota coke. Dr. Ramesh Rai, you just had that candy on the table. You'll have to climb 4 flights of stairs to spend that much of calories. Running 5 kilometers will burn off only 1 donut. So the amount of calories we burn with exercise is very small. Human body quickly learns to conserve energy despite exercise, and the weight loss cannot be sustained. On the other hand, exercise is as important as diet, if not more, for NAFLD, and it helps even if there is no weight loss. Now, lack of exercise is a major cause of NAFLD. This is something which has been proven in various studies over and over. I'll just quote one study, the last one, that is hepatic fat increase by 1.15% with each additional hour of sedentary time per day. That means sit in front of TV and you are gaining weight, gaining NAFLD in any case. There is a strong relationship between the skeletal muscle mass and the non-alcoholic fatty liver disease. It has been shown that people who are sarcopenic, they not only have higher incidence of non-alcoholic fatty liver disease, but also high incidence of fibrosis due to it. NASH resolution can occur in nearly all the patients with enough exercise and dieting. 10 and 16% respectively will lose their NAFLD if there is a less than 5% weight loss. But more than 90% will lose NAFLD if the weight loss is more than 10%. And weight loss is usually achieved by diet and exercise. A systematic review of 24 exercise-only studies in NAFLD have shown that exercise led to 20 to 30% relative reduction in hepatic steatosis. It is independent of weight loss. Even if the patients did not lose weight, the NAFLD did improve. And it was shown that different type of exercises like aerobic and cardio exercises or resistance or strength exercise training or high-intensity interval training have similar effect on liver fat. Any type of exercise you can choose. Therefore, patient may choose any type of exercise that their comorbid conditions will permit. So, people who have osteoarthritis of knee, they can choose exercise of the hand. Even this stress busters kept on your table is a good exercise for the hand. Now let's come to the new kid on the block, that is non-exercise activity thermogenesis, or NEAT. We all exercise only for about half an hour to 1 hour in a day, but majority of time we are spending fair amount of calories, and it is our environment, genetic background, and individual factors like race and gender which determine how much of calories we spend in NEAT. And studies have shown that a very significant amount of calories are being spent with NEAT. And the importance of NEAT is the fact that we'll exercise only 4% of time of the day, while NEAT will be spending energies up to 63% time of the day. So one recommends active living. For example, they say you park your car 1 block before your destination and walk the remaining distance. Take stairs rather than lift. Give your maid a weekly off and do that work at least on Sundays. Office work, you should do standing rather than sitting down, although the patients will feel a little apprehensive if you are standing and examining them most of the time and interviewing them. Disco every evening, otherwise you can dance in the shower, that should be good enough. And it aid to weight loss is very well established. Though logically it should work, no specific studies have been done on effect of NEAT on NAFLD. Studies have shown that with active living, you can double the amount of energy you are spending every day with the NEAT activities. And a lot of studies have started appearing in literature, and they are promising something which is almost magical. You can cut down on your BMI within 12 weeks to nearly half. Weight loss benefit accrual for NAFLD is logical with the weight loss that occurs in obesity, but we do not really know how much it will benefit NAFLD. Let's look at the age-old wine that we have, that is yoga for obesity and NAFLD. The problem here is that most of us view yoga as only exercises. It's not really so. Ashtanga yoga, which was promoted by Patanjali, has 8 steps. And if you look at the first few steps only, that is self-control, discipline, physical exercise, pranayama exercises, if you follow just these 4 or 5 steps in the beginning, I am 100% sure that neither obesity will develop nor NAFLD will develop. However, most of the studies have focused on yoga exercises, and some studies have appeared. They have shown good results, both in reducing the body fat measurement, BMI, as well as increase in the skeletal muscle mass, which seems to be too good to be true within 12 weeks' time. Most of these studies which have shown benefit in obesity due to exercises have appeared in very obscure journals and are technically very poor studies. Unfortunately, robust studies are not available. Even studies regarding NAFLD have also appeared in very obscure journals, and they have been very poorly conducted studies. Better studies are required, and that is a requirement that we have. So I'll summarize the effect of yoga and NAFLD. Yoga practices include all scientific preventive advice that we give for the obesity and NAFLD. They are highly acceptable to Indians, not expensive at all, likely to be highly effective. Effects of yoga exercises alone, scientific evidence is very scanty, poor in quality, and we need robust evidence. This is a gap in our knowledge. Last point, how to motivate people to exercise. I know my time is finishing. I just have half or 1 minute only left. There have been motivational interviewing as evidence-based collaborative communication style that aims to strengthen a person's motivation for commitment to change. Now, this type of interviewing can be done at an individual level by a doctor. So you set the SMART goals for the patient, look for barrier identification, why he can't carry it out, take out a coping plan, and suggest self-monitoring progress. For example, wearable watches are available everywhere these days. But this is just one of the factors that can work. What we really need is the society has to rise to the occasion and take the responsibility of managing obesity, which has now become a public health problem. So we need to look at the urban planning with having playgrounds for the schools, walkability, the gym availability next door. Fast food conveniences can be made inconvenient, and incentives and disincentives should be given for weight loss in obese people. Apart from that, if you look at the political will, it is lacking in most of the countries. But since the time is running out, I'll just mention that inclusion of NAFLD into NPCDCS is an important landmark for India, and we are moving in the right direction. I'll conclude by saying that NEAT, yoga, and aerobic exercises are very effective treatment for NAFLD as well as obesity, as it physiologically hits at the root cause by expending more energy. A difficult problem is to motivate people to how to regularly exercise. Healthcare industry must upscale its act to seriously attempt to motivate people to adopt the lifestyle changes. And if society and nation takes it up as a challenge, no drug may be needed for majority of cases. Thank you very much.
Thank you, Dr. Anand. And thank you all the speakers for excellent talks. Now the topics are open for discussion. I think there would be a lot of heated discussion because all the presentations were quite interesting.
Can I ask a question to Dr. Sunil? We have discussed regarding obesity and NAFLD. Dr. Sunil, is there any data available on how the subset of subjects, I'll not put it as patients, how do the subset of subjects with who are metabolically healthy obese behave over a period of time? What is their outcome as far as the development of metabolic syndrome is concerned, development of NAFLD? Is there any data available on that? One. Second is there any difference in the type of obesity that has poorer outcomes in form of gynecoid obesity or android obesity?
So obviously the visceral obesity is bad as compared to the other ones. So there's a concept of sick fat mobilization. So the sick fat goes to the viscera and it gets deposited and cause NAFLD and so on. And I'm not aware of the other question data on that how the first part.
It's metabolically healthy.
Metabolic healthy.
But obese.
Yeah, so I don't think so there's much data on that. But yes, in obesity they've tried to define it as metabolic healthy and unhealthy. So healthy is one where you don't have all those factors, and they do the genetic susceptibility and environmental factors don't lead to that worse outcome in there. So that data is available.
Dr. Shalimar, we get patients who they come as a family, NASH, cirrhosis, also hepatocellular carcinoma. Now, if they come to you in an institute and they ask you for whether the siblings are at risk, is there any genetic risk? Do you have anything to offer them? And should we offer them genetic testing to find out how proactive we are supposed to be to keep them lean? What would you do in the institute if this question comes to you? Because in an academic setting, the cost for the test won't count.
Right. So I think that's a very important question and important clinical issue which I think we all would be facing in that. So, and every family would be very worried or would be concerned regarding what is the risk. But I think it's we still need more data regarding what are those SNPs, what are those polymorphisms which are associated with increased risk of even progression from simple steatosis to NASH to cirrhosis and development of cancer. So I think we can have if I have an option, I would definitely get their blood samples stored, do a complete whole exome sequencing, and maybe collect such families and do an analysis later down the time to see what is the relationship of different polymorphisms with development. At present, we do not know what is the significance of each of these SNPs, their homozygosity, heterozygosity, because there are so many other factors which you need to account for in a multivariate analysis to say that this polymorphism is alone responsible. There are so much of environmental factors, there are so much of other viral infections, alcohol, and there will be so many other components which need to be accounted for. But yes, we need still more data. I think that's the important thing, and that's the way forward. Collect data, analyze, and then see we can have precision medicine in the long run. That is something which we need to develop.
Genetic susceptibilities work both ways. For example, PNPLA3, it will be easier for a person to gain weight and develop NAFLD. It will also be easier for him to lose weight and lose that fat from the liver if he exercises enough.
My question is to Dr. Ashish.
Dr. Anand, I thought Ashish did very well by saying it's what we eat that is very responsible for the rising tide of obesity and NFL. One minute.
I fully agree with that.
Yeah, because I think it's the healthcare industry, the nutrition industry that lays so much of stress on eating and also says you have to exercise to reduce the consequences of obesity. It's the other way around. You need to eat less to reduce obesity and NAFLD rather than exercise. Because exercise does reduce weight, but not on the long term.
No, but exercise is also important.
It's important.
But zipping your mouth is possibly
it's more important than exercise.
I think due to paucity of time, the organizers are asking us to close the session and we can leave the questions for the dinner time.
May
Thank you
I
very
request
much.
all the speakers of this session to come onto the dais and receive the memento. I request the moderators to present them with the mementos, please.
You know, it just shows how vulnerable we are as human beings. If I give a colleague a topic on nutrition and diet, he will make it out to be the main culprit for NAFLD. If I give A.C. Anand the topic of NEAT and exercise, he'll make it to be the only solution for NAFLD. I'm saying that we all have our little biases, and as we go deeper into a study to make a presentation, that actually becomes much larger in its view. All of them are right. The question only is that, is balance really the key, and is balance really worthwhile? I think A.C. Anand gave a beautiful talk on balance, but you showed an elephant standing on a football. I wonder if ever an elephant can stand and balance on a football, but that's a very common picture on the internet. Thank you very much. Brilliant talks. I think the next time that we have a session, we should have a longish session on eating and exercise, because there's a whole lot of intricacies about it. And I must say that Ashish brought it out so well in the G talk. I was pretty impressed. I thought there are quite a few leads we can take from there. You know, there's a little bit of swapping of sessions. Over to you.
We have a slight change in our schedule today. So now we'll have the session 7, that is the panel discussion on NASH related CACLD. I request Dr. Ashokananda Konar, Professor Ajay Duseja, Dr. Gaurav Pandey, and Dr. Manoj Kumar to come on to the dais. I also request Professor Gaurdas Chaudhary and Professor P.N. Rao to moderate this session. Professor Shalimar as well, please. Thank you.
I think compensated ACLD is a new term, which has been introduced recently in 2015. Is a new term which has been coined very recently. Because CSPH, the clinically significant portability requires an HVPG, and that's the reason that the various other cutoffs and then rule in, rule out definitions have been made, and Dr. Kaushal Madan is going to elaborate on it.
Yeah. Thank you, Dr. Rao, and thanks to HOPE Initiative in ASL and Dr. Chaudhary for inviting me for this particular meeting. And we all agree that this particular meeting has become a brand with so many people wanting to attend it, so many delegates wanting to attend it. So I'll be talking upon NAFLD related CACLD, opportunities for intervention. We'll try to keep it as simple as possible. Very straightforward, 3 or 4 concepts which would be brought about by the expert panelists. So we'll just start with this case, a 64-year-old male who was a diabetic over last 12 years, usually mostly well controlled, now referred by a diabetologist for deranged LFTs. Every one of you see these patients regularly. His BMI was 26. By definition of the Asian definition, he was obese. He also used to drink 2 to 4 drinks up to 3 times a week for last 8 to 10 years. These were his labs, a bilirubin of normal bilirubin, AST 95, ALT 85, normal albumin and INR. His viral markers were negative, ANA negative, and this was a lipid profile, almost normal. Further, on ultrasound, there was grade 2 fatty liver, no evidence of portal hypertension. These were the FibroScan values, CAP of 339 and liver stiffness of 20.9 kilopascals. We also got his MRI PDFF, which showed 20% fat. So the first question to the audience, what diagnostic label do you give such a patient in your practice? Is it type 2 diabetes with compensated NASH-related cirrhosis? What would you write down on your prescription slip at the top? Or CACLD, or NAFLD with advanced fibrosis, or NASH? Remember, there is no single answer to this. For example, in my practice also over last 10 years, I would have used all these labels. So just want to know what you people or the audience or the experts write down on their prescription slip. Okay, so compensated NASH-related cirrhosis, and I think this tells the story that most of us still use compensated NASH-related cirrhosis, and which is not a wrong term, but this is a new term which is being given by Baveno called compensated advanced chronic liver disease to include these patients who are detected to have cirrhosis level of liver stiffness on non-invasive testing, for example, FibroScan, and this is something which we now see regularly in our clinical practice, so we need to know how to manage these patients. So let me ask our experts, Dr. Duseja, what do you call such a patient? How often do you see such a scenario, and how do these patients reach you?
Thank you, Kaushal. I think first question is, what would you call such a patient? I think minus the D option, NASH, I can call him any of this, which means earlier, obviously, I would have called him as compensated cirrhosis, and I still do that, I must say. But then after the cackled terminology has come in, so anybody who has an LSM of 10 or more, we have started calling them as cackled, as long as the disease is compensated. So cackled is also fine enough. So where I don't want to, confuse somebody, I don't want to write cirrhosis, I can even call them as advanced fibrosis also. So I think all three are fine, but then the fourth is not fine because NASH is, you cannot just make. It could be a steatofibrosis, But NASH, normally we take it as a histological diagnosis. So I'll not call him as NASH, but other 3 things I can call him as. The second question which you said was, how much you said? How commonly do we see that? How often do we see that? Okay. So how often do we see that? This kind of scenario is not uncommon, I would say. And to quote this, I will again quote I'll just quote the ICON-D data. This is our data, I think maybe showing this. So, if you go to the previous slide, Kaushal, where we had the the ICON-D, if you have the non-invasive data with you, you have this, yes. So 30% of these patients came with an LSM of more than 8 kilopascals, which was suggestive of, significant fibrosis. At that time, the cackled, concept was not there. So we had not divided them into, 10 or more. But more than 13 were, 10%, which means they were already cirrhotics. So I presume, I think 10-15% of our patients are cackled when they come in, with this. And
what
if
about
you look
diabetic?
at the figures from the diabetic, group, again, there's a very good study by Kuche from, the Medanta, and what he had done was this study, 84% had fatty liver, and of them, again, he took this F2 fibrosis based on LSM of, 8 kilopascal was around 30%, and again, I think 7-8% of them were cirrhotics. So I would say, yes, 10 to 15% of all patients with NAFLD, when they come to this, we come to liver clinic, I would say, just as fatty liver, I think 10-15% of them would be cackled or advanced fibrosis.
So do you think that hepatologists have started using this term, whereas non-hepatologists are still using NASH-related cirrhosis?
Yes, at least at our center, we have started using this terminology. The advantage of this terminology is, even with this 20, LSM which you are shown in this figure, he may not be a cirrhotic.
Right.
That's possible.
And I think
it's F3.
Right.
Suppose you do a histology on him, it turns out to be F3, he would still fit into cackled. So, and cackled will take into compensated maybe F3 and F4 given together. So, unless you do the biopsy, you don't know whether somebody is a cirrhotic or not.
Right. I think we'll come back to that issue, whether they really have cirrhosis or not, whether it's important to do a biopsy or not. But I think this is what they have proposed, a rule of 5. If it is less than 10, then you exclude compensated ACLD. That means it is non-cirrhotic. If it is more than 15, then you can assume that the patient has cirrhosis or NASH-related cirrhosis, or if you want to call them CACLD. So let's proceed. So this is the question to the audience. Now, this is the patient. What diagnostic test would you like to do now? An endoscopy, a triple phase CECT, HVPG measurement to confirm whether the patient has CACLD or clinically significant portal hypertension, or a liver biopsy to confirm your doubts. Again, there may be more than one answer, and maybe everyone is correct. So everyone wants to do an endoscopy. So just a quick one round answer from each panelist. Dr. Konar, what would you want to do next? Just one answer out of these. No explanations.
Right, I would go for an endoscopy.
Dr. Duseja?
Sorry, I missed the platelet count. What was it?
Normal. It was normal.
It was normal.
More than 1.5 lakhs. See, these are the experts. And they see the kind of patients every day. So what would you do?
Maybe I'll go for a CT. I'll tell you why.
Okay, we'll come to that later. Dr. Manoj?
I think liver biopsy should be there next.
He's from ILBS, where most of the liver biopsies are done. Dr. Rao?
I will do only endoscopy because although Babino has said it's not practical for us, whether to do or not to do endoscopy on the basis of the definitions which have been given by the Babino. It's not practical for
Dr. Chaudhary?
I would go for endoscopy and then ultrasound if required.
So I think that was the most common answer, and we'll come to that again when we discuss this. So Dr. Manoj, do you routinely do an endoscopy for these kind of patients? Are you guided by any criteria for going ahead with an endoscopy?
Yeah. So the purpose of endoscopy in this situation would be to find out if the patient is having large varices that need treatment. So there can be some non-invasive markers which could guide us to exclude patients who would not require biopsy, endoscopy. And platelets and liver stiffness are two established markers. And if we find that platelets are less than 1.5 lakhs, if platelets are more than 1.5 lakh and fibroscan is less than 20, then we can safely presume that patient is very less likely to have significant large varices. So these are two markers. And splenic stiffness is also coming in a big way, but more studies are required for that, and few studies have shown that splenic stiffness is much better than liver stiffness, and combination is much better than all of these. So we still need, but the Baveno recommends that LSM more than 20 and platelet counts less than 1.5. If these two criteria are satisfied, we can safely assume that patient is not having large varices and we can avoid endoscopy.
Right. So this is a meta-analysis of 15 studies using Baveno 6 criteria. The negative predictive value of this criteria was 98%. It was excellent for ruling out varices needing treatment, and endoscopy could be avoided, and that is what are the Baveno 7 guidelines. So how many of you from the house, let's have a show of hands, would not do an endoscopy in such a patient based on these criteria? I mean, the practice is still changing, it's still evolving. So I see only 4 or 5 hands. That means 95% would still do an endoscopy, and that's why that answer was there.
Not only we, I have asked many people from the USA. They are only, the guidelines are there, but they don't practice these guidelines there.
Right. So the negative predictive value of this criteria is almost 100%, and they have gone even beyond that. And some say that, which is called the expanded Baveno 6 criteria. So if you have platelets more than 1.1 and LSM less than 25, then you can spare more endoscopies, you can avoid doing endoscopies, and still you will miss only 1.9 patients with varices needing treatment. So these are called expanded Baveno 7 criteria, and they have been validated in subsequent cohorts, and they said that you are able to avoid doing endoscopies in almost 40% patients without missing significant varices. So this is what they have described in this particular diagram, and along this path, there is the natural history of CACLD progressively worsens, and you have liver decompensation, liver-related events like liver-related deaths and liver cancers. So if we look at the natural history of non-alcoholic fatty liver disease, this is from Dr. Sanyal's group, published last year in NEJM. Median follow-up of 4 years, 8,000 person-years of follow-up, and you can see the cumulative probability of hepatic decompensated event was significantly higher in F3, F4 fibrosis. Again, this is the CACLD group. And the risk of HCC was also significantly higher in F3, F4 versus F0, F2. And how do they progress? This is a 20% rule for progression of NASH or NASH-related advanced fibrosis given by Dr. Lumba. So 20% patient progress over 2 years from bridging fibrosis to cirrhosis, and another 20% progress from cirrhosis to hepatic decompensation over next 2 years. And these are the key predictive factors for decompensation as well as liver-related events. And remember, many of them are non-invasive parameters. So you can do away with biopsy if you have these parameters available for you. So another question to the audience, what do you do now? You have detected these patients. That's what we are coming to. Opportunities for intervention. Do we have those opportunities? You've detected a patient like this. How do you prevent further decompensation? So what do you do now to change the natural history of this CACLD? Ask him to stop alcohol completely. Start him on non-selective beta blockers. Do an endoscopy and EVL. Encourage 10% weight loss, diet and exercise. Again, more than one answer may be correct. Okay, encourage 10% weight loss, diet and exercise. Yes, that has to be done, but A and B also are correct. And let's ask, we'll ask about this from Dr. Shalimar. So this is what we did with this patient. Detailed advice to reduce calorie intake by 500 kilocalories, less than his usual intake, regular exercise. We also added vitamin E and saroglitazar, and we can have a discussion on this. You may debate about this, but that's not the part of this particular presentation. So this is what happened to our patient. This was at the time of presentation, his liver stiffness value, and this is now after 9 months, 7.3. Over this time, his ALT improved from 85 to 32. Obviously, he had reduced a significant amount of weight, 81 kgs to 70. This is how his CAP evolved, 339 to 187. The MRI PDFF from 20% to 3%. A success story, which are very rarely seen, but yes, seen by almost all of us sometimes during our practice. So Dr. Shalimar, in this particular patient, at the beginning, do you start these patients on non-selective beta blockers?
Sorry, Kaushal, you have done the endoscopy here?
No.
So,
not yet.
You are asking this question?
Pardon?
No endoscopy and...
No, not yet.
We did an endoscopy.
Okay.
There was small varices. Sorry.
So there are varices?
Small varices.
Small varices.
No, so before I answer your question, one...
You want to ask me a question?
Yeah. So for the question what you raised is one is for the cackled cutoffs. So if you look at NAFLD, there is now data of use of dual cutoffs. So it's not that sacrosanct what you're showing is 10 and 15, you assume, and then as you rule out. So what the current studies, I think there are 3 or 4 studies published which says that, say to rule out, you're looking at sensitivity, rule in, you're looking at specificity. So the studies have taken as 90% sensitivity and 90% specificity. The cutoffs are 8 and 12. And there's a lot of data now coming up, and within that 10 and 15 also, it's cackled. It's not assumed, but then it's most likely, even the Bevino 7 mentions specifically. They can
So that is why they say
cackled.
that consider 15 as a cutoff rather than between 10 and 15. So that's a gray area. Between 10 and 15 is a gray area.
Yeah.
I agree.
And now that there are also models between 10 and 15 or say 8 and 12, you can predict which one of them would have cackle D. Now comes is, do I use non-selective beta blockers? You've shown the FibroScan values in the prior graph. They've dropped down, this patient doesn't even fit into cackle.
So, no, I am talking about at baseline, would you have started beta blockers?
So for this patient,
yes,
with NAFLD diagnosis,
yes,
we don't have data to suggest that in patients with NAFLD with such LSM values, okay. We've got some data published which says that if a patient has a CSPH, you treat with beta blockers. Whether they have got varices, they don't have varices, you prevent further decompensation in form of ascites. That's one of the randomized control trial. Then we've got multiple data analysis, which is individual patient meta-analysis, which includes data from India also from the IL-based group. Again, showing that these patients may have less decompensation when treated with beta blockers. But more important, we need to understand is which subgroup of patients are these studies talking about. In the
so you would not
study which has been published, you got a very different cohort of patients of Hep C not treated. That data doesn't translate into this patient. If you talk in general, somebody who's got CSPH, who's got, as sir categorically asked you on small varices, yes, that group merits beta blockers.
So what do you mean by CSPH for everyone's?
So CSPH is clinically significant portal hypertension, which is defined classically by an HPPG. So the HPPG has to be more than 10. Now the Bevino comes up with a lot of these criteria taking up as LSM criteria of LSM above 25 as you've shown, as you assume CSPH. But look at the bottom 3 lines. It's a non-obese NASH. So you're excluding those group of patients who've got obese NASH. This patient lost weight and you've seen a significant reduction in LSM. I think this is an important carry-on message for all of us is when you're looking at an LSM value, do interpret in a context what is the BMI of that patient. There could be other factors which are influencing this LSM value. And once you start on beta blockers, it's a lifelong story then. Then you're not stopping. There are side effects of beta blockers also. How much do they benefit? I think we still need more data. Yes, there is one randomized controlled trial and the other individual patient meta-analysis. Everybody has started using beta blockers, that is carvedilol, but then we need more data. That's important.
You know, the other surrogate could be, you know, if somebody has varices, you said varices, by definition it is CSPH.
Right. So they were
if
small
you have
varices.
cholesterol, it is CSP. These are all surrogates. HVPG is the gold standard,
Right.
but you know, these are all surrogates. Yeah.
So why I brought this issue up was because one, do we assume CSPH in our clinical practice when it is more than 25? This patient had 20. So if we...
But he has varices, right?
No, so endoscopy was done. Suppose we reach that stage when most of the house says that we'll stop doing an endoscopy, and if a LSM value is more than 25, patient is a non-obese NASH, or maybe a patient like this who has a BMI of 25, 26, obesity according to West is more than 30 or more than 28. Would you be willing to start on beta blockers or not?
Okay, so one thing which I would like to raise is you need to interpret LSM in the context of patient. You have an untreated Hep C patient, untreated Hep B patient. You treat with antivirals, the LSM drops. There is an ample amount of data to suggest that. So do you interpret that within 3 months of therapy, or say 6 months, 1 year down the line, are you reversing out complete fibrosis? That doesn't happen. And in this patient whom you've shown us who's got NAFLD, you're losing weight. Am I presuming that this patient is becoming from a cirrhotic, which each one of us agreed, is becoming now almost like non-cirrhotic, 7.9? Is that what we are expecting with such amount of weight loss?
So
these are the BMI which is influencing your LSM, which I think we need to keep in mind before you take decisions in a particular patient, which has all implications.
So that is why this issue was brought up, that patient has a high LSM, which may be reversible by reversal of the underlying etiology. If that is possible, then yes. If not, and you've done an endoscopy and you do get small varices, then there is no harm in starting beta blockers.
There are 3 factors actually that are driving his LSM. One is AST/ALT is high.
Which was not very high.
Obese. Patient is taking alcohol also.
Yes, that I think that's an important point.
I think one single LSM is not enough because it's highly dynamic and then variable. And if you say the ALD, alcoholic liver disease, more than 110 AST falsely increases the...
So now we come to a stage where all of us believe that one single LSM is not important. You confirm it at least 2 times before you label a patient as having or assuming clinically significant portal hypertension or CACLD.
See, the other important point is you do an LSM today, you do it tomorrow, you do it day after tomorrow. There is significant variability. Which intercostal space you're doing, it also varies. So this is which probe you're using.
So but the next day, if you get a value of 23, that does not take away the fact that patient still has CACLD. I agree with you. You may have a difference of 2 or 3 or 4, but if it's beyond between 20 and 25 or between 25 and 30, the connotation remains the same. I think we have to move forward.
No, I think I fully agree with him. Since I read this Bivino 7, I have been in my mind questioning the wisdom of depending so much on FibroScan, especially in obese patients where XL probe is being used and whose accuracy we know is much less than M probe, and it gives sometimes much lower values. So this has been fairly well brought out, that there is variability in day-to-day measurements, day-to-day variability in the point where it is measured. So I doubt that we should depend so much on FibroScan.
So that's a point well taken. I think we have to move forward.
Actually, the more and more I'm using FibroScan, the less and less I'm getting confused, because daily variability, institution to institution, within the last 15 days, they're done in some other center with the same machine.
Dr. Kaushal, can I ask one thing? Can we use...
Just one small point because we are running short of time.
MRE as a biomarker for MR elastography, which has less problem with the other than FibroScan.
But it's very expensive and not available at most institutes.
Not available, but it's a theoretical discussion we're having.
Right.
I think, Kaushal, one comment. I think that LSM value, we often take it as a permanent kind of a situation where we have confirmed that it's fibrosis, and we have assumed that it will not be reversible and it will be progressive.
But
that
I think
is probably fallacious.
Yeah,
this has been a feature that we have seen. Many a times the LSM value is high, and I think yesterday or somebody pointed out when you have high transaminases or if a person has been taking alcohol, it's often high. And with a bit of time, you find a significant drop, which means that it's not that permanent that you know, one has to label it as.
So I think that is what we have to learn. I think we have to come to understand with all these fallacies, we have to depend on fibroscan. We are not doing biopsies, we are not doing repeated biopsies, we are not even doing baseline biopsies. So we have to evolve a mechanism where our understanding of the patient, our management of the patient has to depend on non-invasive markers like LSM. So I think for that reason, this discussion was really important. So audience, what drug would you have given to this patient? Vitamin E alone, obeticholic acid, saroglitazar, a combination of vitamin E plus saro or vitamin E plus OCA. This may not be in guidelines, but what do you do in your clinical practice? What you would have done with this kind of LSM? This is only for our understanding. D, a combination, because everyone possibly fears that patient has advanced fibrosis. You want to do something more than just a single drug. Maybe that is the reason. And we'll come to that. So, Dr. Gaurav, is there any other intervention that could change the natural history here? Like muscle mass, muscle strength. We've been hearing about sarcopenia. I'll just need 2-3 more minutes.
Yeah, that's absolutely true. There is actually a muscle adipose tissue liver axis that you have very well brought out in this diagram. It's basically insulin resistance, chronic inflammation that drives this whole nexus of fatty liver, adiponectin, myostatin and insulin resistance. We have all heard about weight loss, weight reduction, but weight loss, weight reduction doesn't really improve muscle mass. There are two things in this: NASH, fibrosis and muscle. Muscle has components of strength, bulk and obviously the function. So if we improve the muscle mass, basically meta-analysis as shown in this diagram of over 3,000 patients shows that sarcopenia was directly related to advanced fibrosis. Now this is a very interesting study. Before that, may I come to one more study that was published from Korea. That was from Korea National Registry of 28,000 patients, for which skeletal muscle index was calculated for around 11,000 patients. They showed very interesting things. They showed that if patients had just NASH, NAFLD without advanced fibrosis, NAFLD with diabetes, it did not increase mortality compared to normal people. NAFLD with advanced fibrosis only increased mortality. That was a very important point. The other point that was brought up was, if you increase the muscle strength, then not only fibrosis reverses, survival improves. Again, the study shown previously, the previous slide, may I just go to that, please? Yeah, so this also, this study had around 2,000 patients again from Korea, and they divided the patient based on muscle strength. Muscle strength was basically taken by as hand grip by BMI. So people who had low hand grip and high BMI qualified into Q1 stage, and they had highest amount of fibrosis. So if you increase the muscle strength and
so in this particular patient, Dr. Pandey, sorry to interrupt, but would you want to increase the muscle strength in this patient to improve outcomes?
Yeah, outcome changes. So there are two studies. This is again a 7-year follow-up study. If you increase the muscle strength, mortality improves. All-cause mortality improves, irrespective of diabetes, hypertension, hypercholesterolemia or high CR. So improve muscle strength, muscle bulk, survival improves, mortality decreases, and obviously it's your BMI decreases and SMI improves. Again, this is a study with almost a similar result. This was again a study published in 2018, I guess, from Kim et al. So this also had the same impact.
Last question to Dr. Konar. Any other intervention that could prevent decompensation or improve the outcomes in these patients? What else would you advise such a patient? We don't have a biopsy.
I think we have to have something which can regress fibrosis, because it's all about fibrosis. So we know we have very little drugs, but we can think about statin, which in a compensated situation has a pleiotropic action, and it helps in portal hypertension as well. So statin is one good advice that can be used. And secondly, metformin, though it doesn't prevent fibrosis, but it has effects on HCC occurrence and other positive effects. So that can also be thought of.
Right. So once you diagnose CAC-ADL, what about screening for HCC? Normally, cirrhotics you screen for HCC by alpha-fetoprotein and
and ultrasonography.
So you would do in a patient in which on LSM you detect these patients to be having high LSM, you would put these patients on surveillance for HCC. Yeah, right. So I'll just end here. These are the take-home messages. With the availability of non-invasive tests, there is an increasing recognition of CACLD during routine workups of diabetic patients and patients with fatty liver, and that gives us a huge opportunity to reduce the future burden of CLD and its complications. Lifestyle intervention remains the bottom line. Non-selective beta blockers, obviously with all the caveats which Dr. Shalimar has mentioned, appears to be most effective means of prevention of decompensation. Improving muscle mass and strength also can delay progression, and till we have more data, at least in diabetics, we can continue using metformin and statins in dyslipidemics. Thank you so much.
Thank you. I think we'll close because of lack of time. Much of the discussion can be over drinks and dinner. But I think, Kaushal, you did a very good job. It wasn't an easy case. And the fact that there were so many differences of opinion, that is what discussion is all about. I mean, I think that was very well done. Would all of you agree with me?
Yeah, absolutely, absolutely.
Thank you so much.
We request a memento for speaker from the moderators and the chairpersons, and also a photograph with everybody on stage.
Go ahead with Dr. Reddy.
Next, we have another state-of-the-art lecture, New Frontiers in NASH Management. I invite on the dais Dr. Esil Brewer, Dr. Adarsh, Dr. Sanjay Jain, Dr. Anthony Paul, and Dr. Dilip Todi. I also invite Professor Vinay Kumar and Professor Gaudas Chaudhary to the dais, please.
Is Dr. Vinay Kumar around? Yeah, Dr. Vinay, please come. And if there is a chair that permits, I would probably invite Dr. B.D. Goswami also. He's a very dear friend of Nageshwar Reddy. I was thinking, you would like to have B.D. with you? Yeah. And I must tell you that I am so fortunate. Nagi is a person who is very difficult to get. He and Shiv are the two most difficult people to get. And I am very fortunate and blessed that every time I ask them, they don't say no. I mean, probably next year onwards they will start telling no, but till that time, thanks a lot, Nagi, for coming over. And it's a pleasure to have you in a liver meeting. Over to, I think you people can introduce the topic.
Thank you very much, God. It's a matter of great pleasure to invite Dr. D.N. Reddy for this talk. Dr. Reddy is too well known. He is the chairman of the Asian Institute of Gastroenterology. His contributions in the field of gastroenterology and in the field of endoscopy are phenomenal. Today he is going to talk on a very important topic, and that is the current status of metabolic endoscopy. Over to you, Nagi.
Thank you, sir. I'd like to thank GC for this invitation. I know that actually all of you are waiting for Sarin's talk, and unfortunately it's delayed in the traffic, so you'll have to bear with me for the next 20 minutes till I finish mine before he comes. Now, I've been asked to speak on...
People were getting an overdose of hepatology and fatty liver disease, and probably they were thinking that, look, endoscopy could be a good respite. So, Nagi, I mean, look at it from the other point of view.
Yeah. Okay. So, I think this pandemic of metabolic syndrome and NAFLD is overtaking the world now in all areas, and of course, we have this pandemic of conferences also because of this. These three pandemics are actually poorly managed. In fact, I recently read very interesting statistics that I believe for the first time in the history of mankind, the lifespan of the present generation is going to be less than the previous generations. And this is because of this metabolic syndrome. So unless we conquer this, there are going to be problems. Now what I'm going to do is I'm going to give a very simplistic endoscopic view. I know that as hepatologists, you look into various other things, but I'll try and simplify things because we endoscopists like to simplify things. I'll start with the fact that most of the metabolic syndromes because of insulin resistance. Now, there's a big debate about this. Some may argue it may not be because there is evidence that actually intrahepatic fat starts insulin resistance, not the other way around. But anyway, as I said, I'll keep that argument aside and go to a very simple thing. That insulin resistance is responsible for the obesity, and insulin resistant factor that's being identified now is responsible for the NAFLD. So obesity and insulin resistance are the two common factors responsible for NAFLD, and we have two forms of endoscopic therapy to deal with it. One is the restrictive therapy for obesity, the metabolic therapy for insulin resistance. So this is how we'd like to simply look at it. If you look at, this is a little complicated cartoon, but shows that there are two areas. That is, for restrictive, to produce restrictive techniques, we have several endoscopic techniques like this, the gastric, majority of them to restrict the gastric volume. For metabolic, we have actions on the small bowel. So let's start with the gastric restrictive procedures. All the time, when as endoscopists we were doing these procedures, we are concentrating on obesity, how to reduce weight, and so on. We didn't put much emphasis on what happens to the liver till about 10 years back, when people started looking at the liver enzymes, the liver histology, and so on, after doing many of these restrictive procedures. The first study came from Singapore. A group actually randomized group of patients into those who had a balloon, intragastric balloon put in, and those who did not have intragastric balloon put in. In fact, this study was unique because they did a paired liver biopsies before and after, 6 months after the procedure, to see what happens when a balloon is put in. And this showed very clearly that in patients who had a balloon put in, all their steatosis, other parameters got better, but the fibrosis didn't get reversed. In fact, even the inflammation was similar. So the only thing that happened in patients who had intragastric balloon for 6 months was a decrease in their hepatic steatosis. So this was disappointing. There have been several studies in between, but just 10 years later, probably one of the best studies in this area has been published in Clinical Gastroenterology Hepatology by Barham and his group from Mayo, where they took 21 patients. This was an open label study where they followed 21 patients who had a balloon placed and followed them very carefully with again paired biopsies before and after. And you can see from this slide what they found was there's decrease in steatosis, there was decrease in other parameters, but most interestingly, they found that there's a decrease in fibrosis in 50% of the patients. This was interesting because you can see again from this charts that all the parameters decreased. Fibrosis not as much as others. For example, 70 to 80% of the patients, if they lose weight, their steatosis goes off. But the fibrosis was actually decreased in 50% of the patients. A very important observation part of the study was that there's no correlation between weight loss versus the improvements in liver histology. We all used to think that you lose 5%, you lose fat, you lose 10%, you reverse fibrosis. This didn't happen. So obviously this theory of weight loss versus amount of changes in liver histology was not true, indicating again that there's some other factors in addition to weight loss which may be playing a role in what happens in the liver in these patients. I'll come a little later into this very interesting study that came in this. So this was a sort of a meta-analysis which looked at all the balloon therapies in patients, and you can see there are several of them. Most of them used the balloons that we use currently in practice, the BAB or the Orbera balloon. They were both prospective studies, many of them not randomized, some randomized, all of them showing that there's a decrease in their BMI and also showing that there's an improvement in the liver function test. Now what in fact these studies suggested is that these decreases or changes in the liver histology probably was temporarily. And there's a suggestion at this point of stage, again very interesting suggestion by Barham and his group, that you put a balloon, you control the steatosis, some patients you actually decrease the fibrosis, and then put him on GLP-1 analog drugs. And maybe then you can continue. There's a study which is, interesting study is going on with this thought that you put a balloon, improve the liver histology, and then put them on GLP-1, and then you find that on long term these patients are doing well. Initial results from this study suggest that this could be a good strategy in these patients to control NAFLD. Now, balloon is a temporary thing, what about more permanent methods of restriction? Endoscopic sleeve gastroplasty is, of course, the technique that's being practiced everywhere. I think a lot of people are doing it now, even in our country. And again, this was the first study in 2020, which looked at what happens to the NAFLD in the patients in whom ESG has been done. This was a little disappointing study. You can see that only 20% of the patients, their hepatic fibrosis improved. In the rest of the patients, the other parameters, steatosis came down, inflammation came down, but the fibrosis didn't change. And again, there's no correlation between the weight and liver histology in these cases. Now, we know that there's a huge geographical variation between different countries in terms of liver histologies and what happens NAFLD. We have the so-called lean NAFLD in our country and so on. So what we did in our institute was to try and look at what happens to these patients with NAFLD who underwent ESG. We have a group of endoscopists in our institute very actively doing ESG. And you can see this is a study we published some time back where we looked at all the parameters, ALT, hepatic steatosis index, the NAFLD fibrotic scoring, and so on. And you can see again, all the parameters improved not only at 6 months but 12 months. These patients are in a follow-up now. Now we have about 2 years follow-up. They continue to do well, indicating, of course, we didn't do biopsies in these patients. It's very difficult to convince patients to get biopsies done. But our study now clearly shows that in general, if you look at these patients, both in terms of inflammation versus other histological parameters, there seems to be an improvement with ESG. So I think this is something that we should actively look at. And again, I want to emphasize that there's no correlation between the amount of weight loss and the improvement in liver histology in these patients. And this is again showing very clearly how pre and post EHGs, there have been improvement, especially liver function tests quite dramatically improve. The AST to ALTs come down. Again, there were studies which looked at it worldwide to see what are the differences, and there have been several problems. One of the problems with endoscopy or endoscopic studies is they're not as rigidly controlled as hepatologists want them to be. So therefore, there's a lot of criticism which comes up in editorials on these studies and so on. This is one of the problems, but we have to do with what we have. This is actually another very interesting study, still in press, a group of, again, a multi-center study from Europe and US, which is looking at using POST technique. POST technique is one which also is for restricting the gastric volume endoscopically, but not as much as with ESG. And in this study, again, they're finding that there's fairly long-term now, 2 years, that there's improvement in all the parameters biochemically, and again, they did paired histology is showing improvement. So if you look at all the studies that are published regarding restriction using a sleeve gastroplasty in patients with NAFLD, there seems to be now a fairly good consensus that histology improved by indirect methods. We have very few actual biopsy studies, but definitely if you look at the liver enzymes, the changes are fairly dramatic, indicating that there is significant improvement in these patients. Now, this is regarding the part about restrictive therapies. Now, what about the metabolic therapies? And metabolic therapy is very interesting because the whole concept about metabolism, what controls metabolism, has changed in recent years. A lot of this work actually is by a group called from David Cummings and others working in this area. And of course, we all used to think that pancreas was central to our metabolism, especially the glucose metabolism. We know this is wrong. We know that the metabolic control is totally in the duodenum, the second, third, and fourth part of the duodenum, where all the control lies. There is significant evidence for this, and for example, when we are eating, and this is again just to show you that there are many controls when you take food normally, and the first time the food comes into contact with an endocrine system is in the duodenum, the enteroendocrine system in the duodenum. And when this happens, what happens is the duodenal secretions, the cells in the duodenum, the endocrine cells, secrete two types of substances, the incretins and the anti-incretins. They label incretins, there are specific names now for the many of these. For the anti-incretins, especially now, we have changed it to, because there's factors which are being identified, the insulin resistance factor and the diabetic intestinal peptide. These are the names which actually are being isolated now. Now, what happens is, this two balance together producing an euglycemia, and this is what the metabolic control is about. But what happens is when we take refined foods, this is what is happening now, when we take all these refined foods, the insulin resistant factor increases. Now, why does this happen? This happens because body doesn't want you to develop sudden hypoglycemia. You take a very refined food, your glucose level shoots up, and because insulin level shoots up, you develop dangerous hypoglycemia. To prevent that, the body has developed a mechanism where the anti-incretins, or so-called insulin-resistant factor, comes into play. But unfortunately, in the westernized society, diet and all, we keep on taking this refined food, so the levels of the insulin resistance factor is going up. The whole histology of the second part of the duodenum has changed to favor more secretion of the insulin resistance factor. You develop insulin resistance, and subsequently you develop, of course, everything else associated with this insulin resistance, the metabolic syndrome. And we know, of course, there are several things, not only diabetes, NASH, and so on, but other things associated with this. In the last few years, there's been a large amount of study in this nutrient-cell interaction in the duodenum. And I'd recommend, for at least for the younger colleagues here, to read two very good reviews, one in Cell Metabolism, the other which has come in American Journal of Physiology, which has got extremely large volume of studies done, which has clearly looked at what happens when the duodenal cell at the enterocyte comes into contact with a nutrient, lipids, proteins, and so on. And this is where the identification of the duodenal intestinal peptide, or so-called insulin resistance factor, is being identified. So this is some very good data, and this actually plays into the fact that when people are losing weight because of gastric restriction, it's not just the weight itself that's being lost, which is related to liver histology, but also some other factors like insulin resistance factor, which seem to play a role. So our correlation between weight and histology may not be very accurate because of this. We have a lot of evidence for this, both human and rat studies. Human studies are, if you take biopsies from the second part of the duodenum in diabetics, type 2 diabetics, you'll find a huge volume of enteroendocrine cells, the so-called neuroendocrine cells, we used to call them. The large volume is large, and in rats which have been fed Western chow, again, if you look at the histology, you can actually demonstrate increasingly large number of these cells. So this is one evidence. The other evidence, unfortunately, we had for very long, and we didn't look at it critically as physicians, was when surgeons do bariatric surgery, especially Roux-en-Y bypass, these patients lose weight after 1 month, 2 months. But what happens is they lose dramatically. They have a decrease in their blood sugars in the 4th post-operative day, 2nd, 3rd, 4th. In fact, I've seen some of them in our own institute going to severe hypoglycemia. The glucose levels goes down to 30, 40 without anything, just bypassing the duodenum. So this is a strong evidence that we didn't actually correlate with what is happening in this factor. And one of the most elegant clinical experiment in this area has been done by David Cummings' group, published in Annals of Surgery. And you can see this very interesting. So what they took is they took their patients who had undergoing Roux-en-Y gastric bypass surgery, who were diabetics. And after the Roux-en-Y bypass surgery, you see the food is bypassing the duodenum, going directly into small intestine. They started giving them oral feeds, and within 2 weeks, they became normoglycemic, without any insulin, without anything else. Now, they took permission from the ethical committee and put in gastrostomy tubes in the stomach. I don't know how they allowed ethical committee, but they allowed a PEG tube to be put in. They put in PEG tube, and then they started feeding both orally and through the PEG tube. Then immediately they became hyperglycemic. And when they removed this PEG tube and started normal oral feeding, they became normoglycemic. Now, this is one of the strongest evidence we have that duodenal nutrient passage strongly influences insulin sensitivity independent of weight change. So this is where we're coming to now. There are other factors rather than weight, which is controlling what happens to the liver in terms of steatosis, inflammation, and so on. So this was a very elegant study. So based on this, there were some other things to see what endoscopists can do. In fact, several years back, a group of South American, very adventurous endoscopists started using this duodenojejunal bypass sleeve, the endobarrier. Actually, they started using it for obesity, and they found that obesity, when they used it, the weight loss was not much, about 5% and things like that. But what happened in these patients was a fairly dramatic control in diabetes. And this was a large study which was subsequently done, published recently, where they showed when you use this duodenojejunal bypass liner, which means food comes into the duodenum, bypasses the whole duodenum and goes into the jejunum. They found, you can see, all the parameters improve. And of course, the most important is when ALT levels are high, they are decreased much more. So this is what was the finding then. So based on this, can we do something more permanently? And this is where the DMR, duodenal mucosal resurfacing, came. This was a concept which came from a cardiologist actually, where they started using hydrothermal therapy to burn the duodenal mucosa after raising the submucosa so that it's safe. And then you find response to see what happens. This is the actual technique. Again, I won't go too much in details. I had an opportunity to do this at the Brussels Erasmus Institute. Very simple technique. Anybody doing upper J endoscopy can do this technique. It's fairly simple. You just mark out the second part of the duodenum to the fourth part and put in this balloon, and you burn the complete mucosa at 80 degrees. The initial picture of the duodenal mucosa looks very, very lot of hyperemia, ulcerations, but very quickly it heals. But what's the difference? Difference is if you take histology biopsies from this mucosa, they don't contain the previous enteroendocrine cells, and that's the difference. And the first study published in Gut in 2019, called the REVITA 1 study, clearly showed that these patients, not only the type 2 diabetes for which it was done improved, but you can see the ALT levels, AST levels improved, and of course, HOMA-IR indicating that insulin sensitivity increased in these patients. The subsequent study was a randomized control study done in Europe, in South America, and so on. Again, very clearly showing that we look at what happens in terms of their elastographies, MRI elastographies, there's a dramatic decrease in the hepatic fat. Again, in some of the patients that had biopsies done, we showed a difference in terms of histology, in terms of inflammation, and so on. So what this does is, this duodenal mucosal resurfacing seems to influence all the metabolic parameters. There's not only reduction in A1Cs, AST, ALT, FIB4, and so on, but also in antioxidant levels, anti-inflammatory levels. So this is a very interesting concept. We now have, because of the large amount of knowledge we gained from what is happening in the labs in terms of the physiology of the duodenum versus the clinical knowledge that's coming with this. There's a lot of data which is coming in, suggesting that we seem to be able to control the metabolic process in the duodenum using these techniques. In fact, there's one study in Erasmus which Dr. Jack Javier and the group are looking at NASH patients. They didn't find such a dramatic decrease in fibrosis, but this is a study which is ongoing. In fact, we are doing a study with them now. We're looking at these NASH patients to see if there's some reversal in fibrosis when you use any of these techniques. Of course, burning the mucosa is a very primitive way of doing hydrotherapy, is a very primitive way of doing. This is what they started with. Now we are getting better techniques, and one of the techniques that's now being advocated is electroporation. The same technique that the oncologists use. We can, through the endoscope, we can actually produce pores in the duodenal mucosa and completely destroy the duodenal mucosa. We have a study with IIT Kanpur now in our institute where we're using the electroporation technique in the animal lab, and hopefully, if it's useful, it can come very quickly into thing. And you see what happens, 24 hours, the whole mucosa is completely gone, very safe, and in 3 weeks, the new mucosa comes, but the new mucosa does not contain the enteroendocrine cells. And provided these patients don't go back to the refined diet, we can maintain the mucosa that way with a low level of the cells. There are a lot of new other therapies coming in. In fact, the Israeli company has come up with a laser which can be used through the endoscope to very quickly burn the mucosa. Radiofrequency ablation, what we use, for example, for Barrett's, can also be done for this. So all these new technologies are coming in very rapidly. And my feeling is that, that we have the basic data now. Within the next 2 or 3 years, we're going to get all these technologies to help us use this. And again, you see, there is some evidence that the metabolic process can be altered both by the endobarrier and by the DMR techniques that are available now, and fairly significant group of patients. We now have over 2,000 patients in whom DMR has been done, and showing that very low complication rates, stenosis in some patients, but otherwise complications rates are very low. So I think, again, giving you the simplistic endoscopic view of how we look at it. If we look at endoscopic therapy for NAFLD or NASH, those who are obese, we would suggest endoscopic balloon or gastroplasty. If we're using a balloon, you would like to continue with GLP-1 analogs on long-term basis, but if you're doing only gastroplasty, then maybe you can in fact combine it with DMR. There's a new concept, and this is a very interesting animal study which has been shown by Barham and his group in Mayo, where they combine ESG with DMR, and the control of NAFLD is quite dramatic in these animals at least. So again, the very early human studies are being done in Australia in this. Of course, for so-called lean NASH that we see, only plain endoscopic DMR may be sufficient. So I think again, as I said, I got a very jaundiced tunnel view of this, that endoscopy may be something that's useful, but I think ultimately it's going to be a combination of endoscopy with the newer drugs that are available, and to a large extent this pandemic can be controlled, and hopefully we'll have less of these conferences in future then. Thank you.
Thank you very much, Nagi. As usual, an excellent talk. We can have, I think, how much, 10 minutes? Any questions, comments from the audience? I think while waiting for the response from the audience, I just had one question. Now this obesity and NAFLD is coming in a big way and affecting the children and adolescents also. Of these various technology and techniques, which one is most likely or recommended common for this subset of patients, children and adolescents?
So right now we don't have data on children. There's no clinical data on children because I think these are very early experimental studies and therapies. But my feeling is that DMR is so easy to do. I'm sure DMR could become an easy therapy, at least in certain types of diabetes in children. But DMR is not good for very obese children. In fact, the weight loss is not so much as the DMR. So there you have to do a combination of ESG with DMR, and this would be too early in children to do. So I think still we don't have any clinical data, but I would think that NAFLD in children, DMR may be one of the important ways to treat them. Because it's very simple and no complications.
And of these intragastric balloons, are only these 2 balloons available in India, or the other, now FDA has approved, I guess, 4 balloons, and there are another 2 which are not approved?
Yeah, the 2 one is not, but what is commonly being used now, in fact, the only study which has shown some reversal of metabolic disease has been with the SPATS balloon. Now, SPATS balloon is adjustable balloon where you can pick up the catheter and then you can increase the volume or decrease the volume. So this is the only balloon which has shown to actually make a difference in patients with NAFLD. The other balloons, Obra balloons and all, have been used in earlier studies where they showed decreases in their parameters, but biopsy-wise, SPATS is the one which has made a difference.
Yeah, excellent lecture.
Patients of NAFLD who have gone on to compensated cirrhosis, could they still be considered for sleeve gastrectomy endoscopy?
No, I think once cirrhosis is developed, child-say cirrhosis, then it will be, there are several difficulties in that. One is, of course, there is no question of reversal. The second is that these patients, because of the collaterals that are there, endoscopic therapies or even laparoscopic therapy becomes a little more difficult technically. So I think that's a situation where balloon has been used, especially in obese, well-compensated cirrhosis. The ideal thing would be to use a balloon rather than other forms of therapy.
Very good lecture, sir. So after DMR, actually the patient has to follow up with the diet, otherwise the mucosa will. So if the mucosa comes back with the same, all the problems, so after how many time, I mean, we can repeat these procedures?
Yeah, so this is a very interesting question and very important because this is addressed by these studies. Now what they found is that you can do it every year. So you can come every year, get a top-up done and get your mucosa changed. It's like going for a haircut, but once a year. You can get it done and then,
Yeah, Nagi, as usual, there's a lot of interesting, Shiva here.
Yeah, I can see.
There's a lot of interesting information. I was really curious about the effects that you showed as far as Roux-en-Y gastric bypass was concerned. But isn't it the fact that historically we have such excellent results even with laparoscopic sleeve gastrectomy, which has, in many patients, the same metabolic benefits are seen even in the early post-operative period after surgery. So, but there is no, so do we have any head-to-head comparison that if you're doing the same group, identical patients, Roux-en-Y versus laparoscopic sleeve gastrectomy, are you seeing the difference in the metabolic benefits apart from just the other weight loss and other factors?
Yeah, so Shiva, that's another interesting point. In laparoscopic sleeve gastrectomy, we don't see this dramatic drop in the blood glucose levels afterwards. There is a definite improvement in diabetes long term. As the patient loses weight, the type 2 diabetes gets controlled. So there's a correlation between obesity, intake of, and so on. there also the amount of weight loss doesn't correlate with the diabetic control. So the additional factor may be that because the nutrient intake is less now, stimulation of this, maybe the diabetic intestinal peptide is less, and therefore, so there seems to be a combined factor, but it's not as dramatic as an immediate effect that occurs with Roux-en-Y. The Roux-en-Y, again, people have asked that what happens if it doesn't, in a non-diabetic, for some reason, there's no dramatic drop in sugars. Only in diabetic it happens, and that's because of this hyperplasia of the...
You mentioned about no liver biopsies in some of your patients.
Yes, sir.
So is there a possibility of considering an endoscopic ultrasound-guided liver biopsy combined with your procedure? Because we do fair number in the Nanath hospital.
Yeah. So Parimal, again, this is a very interesting concept. In fact, we're now taken over completely. All our studies, we're doing now 2 major studies, one with Spatz balloon in NAFLDs, and second using this endoluminal technique of restriction. In all our studies now, we have resorted now to EUS guided liver biopsies, and Mithun, I think the groups have published a good paper showing that even for both right and left lobes, you get a sufficient amount of tissue when you do this, and our pathologists again looked at the amount of tissue and says it's as good as doing a percutaneous. So my take would be to now we should shift over from percutaneous liver biopsies to US guided liver biopsies, because you get same material and the patient is very comfortable. With percutaneous, not so comfortable. So we're doing more of that, and I think the future studies in NAFLD will all be US guided, because you can do all the procedures at the same sitting, and you'll get more studies on this.
Sure, thanks.
Even Ajay is young.
Shandil, I hope you're young, no? At least younger than Ajay. Yeah, go ahead.
Sure. Sir, I know there's a trial going on in your place with ESG combined with semaglutide.
Yes, yes.
So, if you can just do one ESG and put the patient on long-term semaglutide, would it be better than doing a DMR along with ESG? And,
so that before we go, actually that's a good point. So what we are suggesting is that ESG is obesity plus NAFLD, where ESG would be useful. Because for DMR, it doesn't act much on the obesity. But if it's patient is not very obese, then maybe a combination of DMR and semaglutide would be a better option. So you can divide your patient. That's the reason why in the beginning I said we have 2 areas. One is obesity related, non-obesity related. Yeah.
So in this patient, you would prefer a DMR plus semaglutide?
Yeah, if the patient is not very obese, the better we do a DMR with semaglutide.
Ajay, yes, please.
Yeah, very nice talk. So just 2 quick questions. One is, since morning we have been discussing about the GLP-1 agonists.
Yes.
And now we also have GLP-1 plus GIP combo, which is tirzepatide, which is probably going to be approved soon by FDA for the treatment of obesity. So this is a once weekly injection. So given the choice between a once weekly injection versus the metabolic endoscopy, any thoughts? Because the weight loss has been shown to be quite convincing even with those drugs, number one. The second is the swallowable balloon Genesis 100. That was initially there, and then there's no data on NAFLD, but then for obesity, I think your thoughts on that.
So for balloon first, the swallowable balloon, there are a lot of problems with that. I wouldn't recommend that because there are complications associated with that. There are instances of intestinal obstruction reported with that, and efficacy is not good as the standard balloon. So there's no comparative RCT comparing standard balloon with the soluble balloon. I think soluble balloon, that's the reason why it's not picked up in US and all. They still don't have regulatory approvals for that. It's mostly used in Middle East, in Saudi and all, where it's a little. So that is one aspect. The second aspect, of course, there are no studies that are NAFLD with this. The second aspect about drugs versus, I think ultimately whatever is easier for the patient will come over. We don't have studies, the combination of GLP-1 with GIP in patients with NAFLD, and if those studies show that it's very good, I think then of course every other mechanical therapy is going to the background. Ultimately, I think it's going to be a combination. In my opinion, it's going to be a combination of these 2 together for better control. But if the drugs are very good, I think they'll take over ultimately.
Shall we conclude? One last question. The last question. Considering the technical feasibility, success rate, adverse events, cost, which of these techniques you think is likely to become the most popular in the near future?
So for obesity, ESG is very simple now. balloon is difficult for the patient to remove it, is temporary. So if it's ESG, endoscopic sleeve gastroplasty, is technically a very simple procedure. Any endoscopist can, his learning curve is only 5 cases. DMR also is a very easy, in fact, learning curve is less for DMR. Maybe 2-3 cases if you see and do, it's okay. So all these are very easy technical compared to, say, pancreaticobiliary endoscopy. The learning curves are very, very early with this. But they're not very widespread used, and that's the reason why they're not being practiced more. But like Ajay says, if there's a race between the drugs and this endoscopic therapy, the drugs win, then these will go into the background.
Thank you very much, Nagi. It has been an excellent talk. All of us really enjoyed it. I'm sorry, some people want to ask questions, but I think these questions can be taken over the dinner.
Nagi, I think I'm sorry we bullied you. This was a guest lecture where normally we shouldn't be asking you questions. But you know, I think people were so keen to ask you, I couldn't hold them back. And also because Shiv was late, so we kept you engaged. Thanks a lot, Nagi. Thanks. By the way, Nagi, there's a little bit of honor that we have to do for you. You have a very distinguished group of people here to honor you with a memento and a shawl. I think Dr. Brood has been a teacher of yours, if I'm not mistaken. Yeah. Yeah, I know. So that's why it's a special privilege. Dr. Vinay Kumar, please. Can you all pose for a picture, please, with Nagi, all of you? Yeah. Thank you so much, chairpersons, moderators, and Nagi. Special thanks to you. We move to the last topic of the day, and may I request Dr. Rinkesh Bansal, our organizing secretary, to make the announcements. And obviously, you know whom we are waiting for, Dr. Shiv Sarin. We usually have this little tit-tats. I told him this time, if you ditch me, next time we are old friends. So he said, never, 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 but he got caught in the rain. So thanks a lot for coming, Shiv. Over to you, Rinkesh.
So moving to last session of the day on NAFLD policy, I am inviting Dr. A.T. Mohan, Dr. B.D. Goswami, Dr. Siren Sethi, Dr. Amitava Goswami, and Dr. Naresh Bansal for the chairpersons. Two important announcement. We have drinks and dinner at 8:30 p.m. Just outside this hall, and tomorrow morning 9:30 we have sessions. And we have Dr. Shiv Sarin as a speaker for this.
Yeah. We have the last talk of the day, and you all know that the NAFLD has been introduced into the National Control for Cancer, Diabetes, Stroke, and Cardiovascular Disease. And the person who was behind it for initiating and is also implementing this program is Professor Shiv Sarin, and we are honored that you could be here to deliver the talk. Dr. Shiv Sarin, please.
Thanks for your kind words, and thanks Gaur, and thanks Nagi for doing the initial slog overs for me. I just got stuck up. The enthusiasm with which Gaur does it is addicting. I bring greetings from ILBS, and I'll briefly touch few topics, parts of it, before I go to the main policy. The global prevalence is 1 in 4, in diabetics 1 in 2, in obese almost all. Please remember these. In Asia, 1 in probably 3, and India maybe 1 in 4. And this slide tells you that this is the century NAFLD will drive. And liver cancer, this data shows in maroon, is that 35 to 40% of all cancers are due to NAFLD, and India, like some other countries, so 40%, and that's what we also found, that 35% of all HCCs are diabetics. This is the data just published of about 2,600 liver cancers, and in this you will see that diabetes is 40% and NAFLD 35%. So it's a problem. And I want you to pay attention to these few slides, because that makes these slides were used for policy decisions. So if you have more than 10% fat in the liver, you have steatosis. These ballooned liver cells will not allow insulin to come inside. If insulin doesn't come, more and more insulin is produced, and therefore, very crudely, diabetes can develop. And therefore, we believe, like many others, diabetes is a liver disease. And then the journey you know very well. I won't take time. But what is important is, if you go and get your blood test or somebody else gets it, it's a high cholesterol or triglyceride, you just take a pill, not realizing from where has it come, and that's fatty liver. So all dyslipidemics have fatty liver. Then this goes and deposits atherosclerosis, heart disease, stroke, gallbladder stone. So they all are a result of inflammatory, or what I call as surplus nutrition inflamed hepatometabolic syndrome. This is an old slide just to tell you that high ALT, let's say it is 80, will mean that the intrahepatic triglyceride levels are very high. This study, old, but tells you if you take NAFLD and 14-year follow-up, almost 4 out of 5 NAFLD may develop IGT or type 2 diabetes, and the incidence, the risk is high, but regression reverses. This is the Framingham study. High ALT in young children below 20, the diabetes risk is 5 to 20 times. And ALT correlates not only with fatty liver, dyslipidemia, diabetes or its risk, or hypertension or heart disease and risk, but also all cancers, liver, breast, prostate. And this is based on another study from Korea, where an ALT of 20 was considered as normal. Anything above 20, the risk increases for all cause or liver related. And what we considered in India as 40 as normal, all cause mortality and liver mortalities increase in a 10-year follow-up. I'll briefly rush through increased risk of CKD in those who have NAFLD. Increased risk of myocardial infarction and stroke in NAFLD. First cardio event and death in COPD in NAFLD with fibrosis. NAFLD and cancers, the thyroid cancer, you can see the risk increases. Lung cancer, stomach cancer. So the central thought is liver fat precedes flames, and therefore diabetes, hypertension, CAD, or NCDs, but the core, and all of you would agree, is liver fat. So to reduce diabetes, stroke or heart or kidney disease, we need to reduce fat in the liver. And I have forgotten to stress upon PCOS or maybe sleep apnea and other similar problems. This is just a brief data of ILBS of about 4,000 NAFLD patients. Of the 4,000, you would see that about 50% of them have either diabetes or hypertension or obesity. So NAFLD has a second phase. Now what is the magnitude in India with 1376,816 above 18 years? With 30% estimate, you have about 244 million. That is 25 crore log NAFLD se projected hai. So we need policy initiatives urgently. Now this was the policy initiative which was led by Jeff Lazarus, and I like these slides very much. Something I'm doing, or? I know that NAFLD should make noise, but all right. So please pay attention to this. Policy initiatives at leadership. We were lucky. Human and economic burden, we don't know. Awareness is 1%. 99 out of 100 physicians say, क्या है यार, fatty liver तो मेरे भी है. Treatment and care, nothing. Policy strategies and whole of society approach, missing. Patient and community perspectives, lacking, and defining and implementing models of care, totally lacking. And I want you to read this beautiful paper. I must have read it half a dozen times. Let's say leadership role, and we are lucky that Dr. Duseja and Dr. Sanyal and many others are here. The national and regional liver associations in collaboration with government and stakeholders. That's the leadership requirement. Do you agree with this? We need leadership, societies and others. What is the national status? There are taxes on sugars, but there is no school-based environmental cultural intervention. Our schools have no initiative, and obesity in the kids is close to 20%. There are no national guidelines on physical activity. There is no incentive for workplace and healthy lifestyle. If you look at Australia and New Zealand, almost everything is yes. And they are very healthy, quite unlike India. So we need, and I'm working on all these initiatives at a separate level. Now, as Dr. Narendran said, integration of NAFLD into the national program for cancer, diabetes, stroke, and cardiovascular disease. So this was a groundbreaking initiative on February 21, just about 2 years ago. And as it was covered in JHEP, that out of 100 marks and 102 countries, in the preparedness for fatty liver, India scored 42.7. Much less. Still it fails. It doesn't mean कि यार 42% हैं तो pass हो गए. No. But yes, amongst 32 countries who got 0, India did better. Now, please pay attention how each one of you, each one can help. First is health promotion, awareness generation and promotion of healthy lifestyle. I'm not going into details of this. For a whole of society approach, whole of society needs to understand fatty liver disease. What is whole of society? I myself, I don't have to go to a doctor. If I have fever, I know I have fever. So self-testing, screening, everything is self. And early detection. All this is done by the person himself. Point of care is not required. You are the point of care. Let's see how we achieve it. Then point of care diagnosis to confirm, stratification, referral, access to affordable treatment and rehabilitation. Now this is what we covered and was based on the Lancet paper. I would like to spend a minute with each of this. This is your ASHA worker. This is a bottom-up approach. What do you need in this? The ASHA worker is just asking questions from the population. आपके घर में किसी को blood pressure है, diabetes है, heart disease. So she is just asking just risk factors. 10 of these I will come to them. Then she refers to a high risk individuals to the PHC. In PHC, you identify waist-hip ratio, whatever you would like to do, and NAFLD suspects. Then you refer them for liver fibrosis. Management of uncomplicated is done there. Then they go to CHC. Please see, it is 100,000 population where you diagnose and risk stratify. इसको blood pressure, diabetes plus liver. And then district level hospitals are there. Now if you do this, let's say at the PHC level, 30,000 population, above 30 years, I have not taken above 18 because that becomes huge, it's about 10,000 people. इसमें से B and C निकाल दिया. Then ultimately you will see that you have 714 those who might have a problem. NAFLD load at CHC level 100,000 is about 357. But this is not every day. This is the total burden. No panic. You can do it in 1 year. Then the NASH cases which go to a district hospital about 100, cirrhosis 20, liver cancers 2. Now if we just manage this scenario, maybe 1200 people just need to handle 1200. But while doing 1200, we will find out so many diabetics, blood pressure, heart disease. So you are going to find with this method, bottom-up approach, an early screening diagnostic approach. And this is what we are pushing, and I would like you, anyone you meet, you can just communicate this. We need to have whole of society approach. The next thing, amongst ourselves, what can we do? Change our attitude. Believe me, change your attitude. I have seen children, when I was at GB Pant, every patient who used to go for angiography, the family would come, 3-year-old Muslim child, 5-year-old child, and I would do an ultrasound, 7 in the morning. They have grown up. Many have come with gallstones, many have come with liver disease in last 20-25 years. So please change your attitude, and from so what approach, liver fat is a fire alarm. I showed you the data. So how do you make whole of society? Every tailor has to be taught that don't fit jeans onto the guy. Ask him to fit into the jeans. And what is that fit into the jeans? Waist. When you go for a haircut, teach your barber, please do that. Teach your barber, anybody who has these warts or these black lines, भैया तू जाके डॉक्टर को दिखा ले. If you teach all barbers, every male person is covered unless he has some other better ways of handling. If he doesn't have hair, I can't help it, but otherwise you will cover the whole of population. Do you agree with this? All barbers. And teach your friends to tell the barbers. Because of this reason, the MAFLD term came. MAFLD is a new term. Everyone will simply understand. I'm not going into debates what you and others have been doing. But karna kya hai? All diabetics, 50 out of 100 have fatty liver. Maybe, in my opinion, 60-70%. Overweight or obese, 100%. 95% have fatty liver. So who has fatty liver? Obese, diabetic. So this is what it is. Now comes the lean, less than BMI 23. So the new term is metabolic dysfunction associated fatty liver disease is for everyone, whole of society approach. This is a beautiful article published in Hepatology Communications in NAFLD in a primary care setting in US. Now these are number of people. They have gone to a diabetic clinic or a primary health care. So these are 10 people. Out of 10, 30%. So NAFL is in 30%, NASH is in about 10 to 12%, and NASH with advanced fibrosis maybe about 5 to 10%. Or they go to diabetic clinic, out of 6 people you will see 3 have affliction. So diabetics 3 even in US. So you have a navigator, you will screen them, FIB4 less than 1.3, low risk, FIB4 more than 1.3, and then vibration control your transient elastography if it is above 8. And then you refer them to a liver clinic. It's very simple, can be easily done. This is what we use at ILBS. Above 8 or 8 kilopascals, we think it may be stage 2 fibrosis. He may go for a liver biopsy. If it is less, he goes into a weight reduction and other programs. And this is what Arun published beautifully. I don't know if he's around, but this was a beautiful paper, and this confirms the need for a NAFLD diagnosis. Agile 4 score is your transient elastography, platelet, AST, ALT, diabetes, sex and age. And in this, age is not there. Now, all the NITs, non-invasive tests, are for excluding. This is to exclude that you don't have liver disease. But this is not confirming FIB4 of 1.3, then you do go for biopsy. The Agile score is the score by which it is inclusive. You are diagnosed, and the diagnostic accuracy, not exclusion, is about 90%. I'll not go into details, but use Agile 3 and Agile 4. Now, what does it mean? It means diabetes and liver disease is same. So, NAFLD actually is a very simple primary care diagnosis. You have a diabetic, obese or metabolic syndrome, primary care physician or even nurses, community-based providers, a mobile van and a small lab. You may not even need a lab. And you can have a whole of society approach. Based on this, 2 years ago or more, we had the first guideline of NAFLD in the world. And there is a hot debate. The Westerners don't like, the Europeans don't like, but well, if people like, if it makes sense, maybe it will be worth. So what is the difference between NAFLD and MAFLD? MAFLD or NAFLD? 5 P's must be satisfied. Patient, can you identify? Yes, भाई ये overweight है, ये diabetic है, fatty liver है, screen कर दो. Physicians, a common physician understands at primary, secondary, tertiary level. Pharma understands भाई diabetes वाला इधर भी जाए, hepatology या gastro के पास या diabetics. Drugs are same, teach both of them. The pharma will teach both groups. Develop drugs together. Policy makers, so easy to make them understand. And public, I guess time will tell us. So what are the interventions? What you do for CKD? What you do for hypertension? Bhai cholesterol kam karna hai, ye khana kam khana hai. They are same. So NAFLD or NPCDCS, the interventions are same. There is no difference. So my carry home and task for all of us is, if you want to reduce in India in next 1 decade, then join hands to reduce diabetes, non-communicable diseases, prevent, treat, screen NAFLD right now. Thank you all for your kind attention.
Thank you, Dr. Sarin. Sorry for the interruption which was there, but in spite of that, we really enjoyed the...
Thank you.
And one question which I will ask before how do we study the impact of this policy? You know, I think it will be a very difficult thing as people are aging and the weight of the people is increasing. How do we study the impact of this program? Is there any plan of how to measure the impact 5 years from now? Do you expect any change in the thing?
I wanted a change, but I am very disappointed myself. There is very little sensitivity in the population. For NAFLD, nobody understood. MAFLD, they do understand there is a problem, but we have to connect to endocrine society, metabolic society, obesity society, cardiology society, which we haven't. We all work in our silos. So we need to have some kind of cross connectivity. But yes, if this works in 1 decade and you can reduce 2%, it's not increasing diabetes, it reduces 2%, I think our mission is over. Most countries are doing this now. By 25, WHO and they will pass this resolution in another 2 years or so.
Thank you, sir, for this wonderful talk and making it very simple. I just wanted to ask, what will be the role of a private sector or a private medical college hospital? Because in India, public and private, there's a disconnect.
So private people are very rich. My suggestion is you buy 2 weighing machines for each group of people. हर आदमी के लिए 2 weighing scale दे दो, एक गवर्नमेंट में फ्री, एक अपने यहाँ. The role of private sector will be remarkable because you can set standards. Government mein there is no weighing scale. What can you do? And otherwise, for training, I think you should all train your nurses. Many more. 70% are there. I think you should train them more. But that was in a lighter way, that there are no weighing scales in government schools or hospitals. Provide that.
Thank you very much. I think this was a guest lecture. So I think we have troubled him with questions. I know he's very happy to take them. And coming from such people like Dr. Narendranath, who's been like, he's been senior to you.
Yeah.
Obviously. So that's why we called him over to moderate. So thanks a lot, Shiv.
Thanks.
May I request all of you to kindly honor Shiv with a shawl and a memento. And Shiv, if you can be in the center. Yeah. I'm really sorry for this music. There's a wedding going on, and I can't stop it. So. Thank you very much, all of you, and Shiv, thanks a lot for all the trouble you took to come. I'm really grateful. So is for Nagi. I think you have been a fantastic audience. You have been sitting here from 3 o'clock. It's about time we enjoyed. I think a big round of applause for the audience, please. Tomorrow we'll probably move a little bit more and ask more questions. But today let's go and enjoy ourselves. There'll be drinks and dinner. And we meet tomorrow at 9:30 in the morning. Tomorrow is going to be heavily pharmacology and a beautiful debate in the morning to start with. Thank you so very much. Rinkesh, any announcements, please?
So, to match the threshold outside, we are inviting you to join us on drinks and dinner.